Good morning to all. A warm greetings to one and all present here. On behalf of PPG PHYSIOCON 2K21, organized by PPG College of Physiotherapy, we heartily welcome you all for the third session of PG paper presentation. Myself, Maithili Gunashekharan, Assistant Professor in PPG College of Physiotherapy. I am very glad to be a part of this event. It's our great pleasure to welcome Dr. Syed Zubair Pegasti, Associate Professor of Royal College of Physiotherapy, Nasik, Maharashtra. We are honored to have you as a panel member, sir. Before getting into the event, all the delegates are requested to ensure proper network connectivity and be in live during your allotted slot time. We will start with the PG paper presentation. Now I welcome Nauhim Fatima, Wells Institute of Science and Technology, Advanced Science, Chennai.
Hi, my topic is the efficacy of physical and psychosocial support in juvenile fibromyalgia syndrome. Fibromyalgia, it is one of the most common pain condition occurring in 2 to 6% of the pediatric population, and it is defined as a chronic diffuse musculoskeletal aching pain that is widespread and which lasts for at least 3 months, and it depends on the criteria with predictable tender points. Juvenile fibromyalgia syndrome is a condition where girls are more commonly affected than boys and the age of onset is approximately 10 to 13 years. The common manifestation is sleep disturbances, chronic headache, irritable bowel syndrome, stiffness and swelling in the joint that has a direct negative impact on patients' quality of life, and due to this they experience stress and anxiety. Treatment in childhood fibromyalgia has a major focus on physical and psychological performance. Exercises improve the fitness and increase the physical activity level. Psychosocial support have found to be effective in reducing their functional disability and the ability to cope up pain in adolescents with juvenile fibromyalgia syndrome. The background of the study is there is a negative effect on the well-being of pain in adolescents with juvenile fibromyalgia that is associated with functional impairment that commonly leads to avoidance in regular activities, school absenteeism, and poor social functioning. In this study, we determined the effect of reduction in pain intensity in children with fibromyalgia with physical exercise and psychosocial support. Therefore, the aim of the study is to analyze the effect of reduction in pain intensity with physical exercise and psychosocial support in juvenile fibromyalgia syndrome, and the objectives are to reduce pain, to improve functional activities, and improve the self-efficacy of the children. It is a quasi-experimental study with convenient sampling, and the 10 samples were taken in Zamo Physiocare Center. The inclusion criteria are adolescents aged between 13 to 17 years diagnosed with fibromyalgia, pain which lasted for at least 3 months, and children with VASCO greater than 7 were included. Exclusion criteria are other medical conditions such as cerebral palsy, fragile bones, and children with other rheumatic diseases were excluded, and uncooperative patients were also excluded from the study. The participants were selected based on the inclusion and exclusion criteria were 10 female children, and informed consent were taken from the parents prior to the study. The study duration was for 12 weeks and 3 sessions per week, and each session for 1 hour that was divided into 30 minutes for physical exercise and 30 minutes for psychosocial program. They were explained about the procedure, and the pretest was done based on the outcome measures. Brunig's Ostritsky test for motor performance. It is a measure for gross motor, fine motor, balance, and coordination. It has 8 subtests in each, and the highest score represents the better performance. And the WATS scale is used to assess the intensity of pain, and they are given an 100 line, and the patient were asked to mark the level of intensity from no pain to worse pain. And periodic quality of life, which is 23 item score, which assesses the physical, emotional, social, and school functioning in 13 to 18 years of children related to health and quality of life. The exercises given were physical exercises are animal walks such as frog jumping, elephant walks, squatting, running up and down the stairs, stepping in and out of the circle. Frequent intervals were given in between the program if the children felt low. Psychosocial performance, it is a second phase. Art therapy was given, and the children were asked to draw and paint their own sketches. Relaxation such as meditation and breathing exercises like pranayama was given. The post test was conducted with the same outcome measures after the 12-week of intervention. This is the data analysis where you can see the visual analog scale that has significantly decreased from high to low, and the baud scale has been increased in the motor performance such with well above average, and period quality of life has been increased and has a fair level. Therefore, the result of the study is there is a significant difference in the baud scale, periodic questionnaire, and VAS, introduction of pain intensity with physical exercise, and psychosocial support with juvenile fibromyalgia. Discussion: children with fibromyalgia exhibit significant improvement on all the functional and pain measures that was applied, and BOT has found to be improved, and that these children have well above percentage and reinforces high level function. The subjects also reported that the level of pain was also decreased. Kashiken, he examined the effect of pain and depressive symptoms in juvenile fibromyalgia and in adolescence to young adulthood, and he found there is a significant association with school absence and poor emotional functioning. An important aspect of a study is to support of the child and the family. During this intensive program, there was a high level of increased function and decreased pain, as well as improvement in overall coping up skills by self-report and objective measures in children with juvenile fibromyalgia syndrome. Therefore, the study concludes that children with fibromyalgia can be treated successfully with physical exercise and can be given psychosocial support to achieve marked reduction of pain and experience increased quality of life. These are my references. Thank you.
Thank you, Fatima. Now I would like to call Dr. Syed Zubair to ask questions.
Good morning. Am I audible, Miss Fatima?
Yes, sir. Good morning, sir.
Fatima, just I have a few questions for you.
Okay.
I want to ask, what is? Have you done the validity of test for your motor performance? What you have used? Have you done the validity?
Yes, sir.
Okay. So what was it? How much it was? Validity? How you have done? May I know how you have done validity? How you have validated the test? It was already validated, or you have validated?
Sir, it was already validated, sir.
How much was the value? Any value for it?
1 second, sir.
One.
Sir, I have it in my Word document. Can I
Okay. One more thing, for psychosocial support, you have told you have given like art and yoga,
Yes.
like painting and sketching. So that
Yes.
is already part of a school curriculum. Like school, obviously there will be a drawing period, and I think since last 4-5 years, yoga is also incorporated into the activities of students. So how it is going to make a difference from your study? Because all schools almost.
Sir, this gives relaxation to the students, sir. It improves their mental health.
Agree. But that is already there in school syllabus. Already it is given. Drawing is there, yoga is there, PT is there, activity is there. How you are adding value to that, or you are giving anything additional to that?
No, sir.
And
It is just to improve their performance, sir.
And usually 13 to 70 age group is more active. So have you done any, like, what is their activity level, daily routine, that it is every children is having same activity level or not? Because some are like home bounded.
Each children, they were different from their own activities.
Exactly.
So they had different performance.
Yeah, exactly my point. Some will be like reserve kind of, some will be more active. So their physical activity will be different for every children. Na? So have you evaluated any pre-evaluation of their physical activity?
So that's why we got this BOT scale, sir.
Okay, thank you.
Okay.
Okay, thank you. All the best. Thank you, ma'am.
Thank you, sir. Next call upon Batruva Himansu De from JG College of Physiotherapy, Gujarat.
Presenting my topic now. So the title of my topic is Patient Reported Quality of Care Among Osteoarthritis Patients. Okay, so background. Osteoarthritis is a chronic degenerative disorder of multifactorial etiological characterized by loss of articular cartilage, hypertrophy of bone and margins, and subchondral sclerosis, and range of biochemical morphological alteration of the synovial membrane and joint capsule. Clinical manifestation of knee OA are slow development of joint pain, tenderness, stiffness, joint swelling, limited mobility, and joint deformities. Osteoarthritis is the second most common rheumatological problem, and it is most frequent joint disease with prevalence of 22% to 39% in India. High quality primary care is of clear importance for such a prevalent condition that has both major personal and social impact. BMI is a risk factor for OA. The various modifiable risk factors are repetitive movement of joint, obesity, infection, and injuries. The occupational physical activities include monotonous motions and great forces such as kneeling, squatting on joints, climbing, and heavy weightlifting. Need of study. Knee OA is more important not only for its high prevalence rate compared with other types of osteoarthritis, but also its presentation at earlier age group, particularly in younger age group of obese women. Arthritis of the knee or hip in particular can severely compromise activities such as walking, climbing stairs, and using bathroom. In order to determine, monitor, and improve quality of care, quality indicators based on standard of care may be used. The quality indicator can be used to evaluate whether the patient's care is consistent with the indicator at a population levels. This could be used by healthcare providers to capture individuals patients need objective to evaluate patients reported quality of care among OA patients. Methodology, source of data, different hospital and clinics of Ahmedabad, population osteoarthritis of knee patients, study design, observational studies, sample technique, purposive sampling, sample size 50, duration of study 2 months. Inclusion criteria, willingness to participate, osteoarthritis of patient, age 40 to 70 years of age, both male and female, who is currently taking physiotherapy treatment. Exclusion criteria, unwillingness to participate, already having any psychiatric or neurological condition, patient who underwent total knee replacement, any recent musculoskeletal injury at knee joint, any surgery at knee joint. Outcome measure self-made pre-assessed questionnaire containing 70 questions regarding OA of knee, obesity and its management, lifestyle changes, physiotherapy treatment, external aids, assessment of pain, surgical treatment. Procedure. Questionnaire was made. Questionnaire was assessed and modified, and Google form was made. Various hospital and clinic patients who are diagnosed with OA knee joint who fall in inclusion criteria were approached for the survey. After explaining about the study, consent form was taken, analysis was done. Result, 50 patients were analyzed and mean age group was 58.3, 72% were female, whereas in 48% were having OA, 36% were not having osteoarthritis, 36% were having OA on right side, whereas 16% were having it on left side. So this is the chart where when it shows the side of OA and its percentage, knowledge and information, quality indicator regarding patient's knowledge and information of OA was assessed, and 51% patient was aware. So this is the pie chart for the same. Physiotherapy treatment, second quality indicator which was assessed was advice, who were advised for physiotherapy treatment, and this is the pie chart for the same. Overweight in management, quality care indicator was used to assess whether obese how much percentage patient were obese, and they advise for lose weight. So this is the pie chart for the same. External aids, 29% were having no difficulty, 27% were having difficulties, and 44% were not having any difficulties, and in which 27% patients were advised for external aids. Pain and assessment of pain and different treatment alternatives such as physiotherapy treatment, modalities and exercise and pharmacological treatment and their side effects for that were assessed, and the result is in the pie chart. Surgical treatment, knowledge of surgical treatment option for the osteoarthritis of knee joint was assessed, and 24% were having not severely OA, 36% person were having knowledge regarding the same, and 40% was not having any knowledge. So lowest quality care indicator among was 27%, which was external aids, whereas highest quality indicator was 70%, which is physiotherapy treatment. Discussion, OA indeterminately occurs in elderly age group, occurs in females above 45 years of age. This study used 6 evidence-based indicator to measure the OA. In this study, quality care indicator was found low in external aids, whereas overweight and its management as well. Same should be improved to treat the patients with OA. 70 question covered single yes, no, and not applicable, don't remember, not overweight, and no pain responses options. So this is the chart where this shows the domains, and this shows the number of the question. So the first domain, patient education and information, were having 4. Treatment was having 2. And advice for obesity was 2. External aid was 3. Assessment of pain 5, and surgical treatment 1. Conclusion: in attempt to improve and deliver healthcare to patients with OA, quality indicator consists with recommendation for management have been deployed to direct practitioner and potentially to evaluate care delivers to patient with OA. These indicators will improve the quality of life of the patient with OA, not by reducing pain and functional impairment associated with OA, but also reducing occurrence and of adverse event from treatment of for OA and their associated mobility and mortality. So this is the bibliography of my.
Thank you, Dhruva. Now I call Dr. Syed Subaisar to ask questions.
Hello, good morning.
Good morning, sir.
Good morning, Dhruva.
Good morning, sir.
Presentation was like a bullet train. By the time I
Sorry
could see
for that.
something, it was yeah. So I have few questions for you. Why
Yes,
you
sir.
have done purposive sampling, Dhruva?
Sir, because I want only OA patient which were taking treatment current physiotherapy treatment currently. So the sampling technique was purposive sampling.
No, that you could have assigned randomly. After taking OA patients from them, you could have done random sampling. So purposive would have given a bit of bias in your study. Is that you could have taken the patient which might be suiting your study or result?
No, actually, the patient who were currently taking physiotherapy treatment, who didn't underwent any surgeries, who didn't have any knee joint injuries or musculoskeletal conditions, I taken on only those patients.
Still, I feel purposive sampling, you could have been like at least randomized sampling. Another question, like why your range of age is 40 to 75? Don't you think it's too huge range? Like
Yes,
your average
sir,
mean is also somewhere
yes,
around
sir,
58
yes, sir.
point. Yes.
Yes, sir. That would be my limitation of my study because I have taken huge number of patients, age of patients.
And because your mean was also coming somewhere around 58 point something.
58, yes, yes, sir.
Yes. And you have mentioned that chances of ONE is in above 45 years of age, but
Yes,
your range is from 40 you have started. So if your 2-3 samples, those who are from 40-41 age, so that would have again given like a impact on your result also, na? That would have given your range is 40 to 75.
Yes, sir. Yes, sir.
It is post menopause. We consider ONE can be like most prominent and prevalence is
The
there.
ratio, yes, sir. The ratio starts from 45, but there are chances like some female patients who have early menopause, they have chances of getting OA early after 35 year 40 also. So
yeah,
that's why
those cases are considered as exception. An exception cannot be considered as an example. Okay.
You are right, sir.
Yeah. Okay. So what you have included, like why right, left, you have like considered. So how it would have been important whether they are having right ONE or left ONE?
That don't make any major difference in my study, but I have taken right, left, and bilateral also, so there won't be any bias for bilateral knee also and for right and left also.
But you don't think if bilateral person is like having more severe difficulties in daily activities and functioning compared to right or left single knee person?
Yes, sir.
So your that quality indicator must have, that result must have affected because of that.
That would be another my limitation of the study.
Okay. And have you validated your questionnaire? Is validated?
No, sir, not now.
You are still you have to validate it.
Yes, sir. Yes, sir. I know that.
Okay. Thank you.
Thank you so much.
Thank you.
Thank you, sir. Next call upon Aditi Mahesh Dasondi from Government Spine Institute on Physiotherapy College, Gujarat.
Warm greetings to everyone. Myself, Dr. Aditi Mahesh Dashondi, currently pursuing my Masters in Sports Physiotherapy at Civil Hospital, Ahmedabad, Gujarat. The topic of my paper presentation is accidental breaches of doping regulations in sport. Is there a need to improve the education of sports physiotherapists? What is doping? Doping employment of different prohibited drugs or adaptation of different illegal methods by athletes to improve their performance without considering the violation of anti-doping rules set by World Anti-Doping Agency. The protection and improvement of health of athlete is prime objective in sports. Team of physicians, coaches and physiotherapists collectively work on it and maintain the integrity of the competition. The earliest records of doping in sport originate from the ancient Olympic Games. There are several ADRVs listed, and the doping offense occurs when a sports person tests positive for a banned substance, irrespective of the manner of ingestion. Nowadays, physiotherapists have become an important and essential parts of sports team in preparation of athletes in providing treatment, rehabilitation of injuries, maintenance, and recovery interventions. The aims and objective of my study was to investigate the attitude of sports physiotherapists towards doping. Studies are conducted to know the attitude, beliefs, and knowledge about doping in athletes, coaches, and medical professionals, but very less, or to our best knowledge, nothing is known among the sports physiotherapists. From the data collected, better awareness can be created among the sports physiotherapists. Methodology. The study design is cross-sectional study. The setting is an online Google form questionnaire, which was conducted within 15 days of duration. The population is sports physiotherapists, and the method of sampling is convenient sampling, and my sample size is 67. Methodology. An online Google form was prepared using Performance Enhancement Attitude Scale PEACE containing 17 items, and a 6-point Likert scale was used for scoring. Lower score was suggestive of negative attitude towards doping, while higher sided score showed positive attitude. The minimum score was 17, while the maximum was 102. The participants were asked for online consent for their participation in the survey, and the information provided was assured confidentiality. The inclusion criteria of my study was those who were willing to participate in the survey, subjects who were strictly sports physiotherapists or had a degree of MPT sports, clinical sports physiotherapists with at least 1 year of clinical experience on field, male and female, both were included. The exclusion criteria were those who gave negative consent for the survey, subjects with bachelor's of physiotherapy degree, and subjects with less than 1 year of clinical experience. Performance Enhancement Attitude Scale is a self-reporting questionnaire instrument measuring attitude towards doping with known reliability of 0.71 to 0.91. The 6-point Likert scale is shown as below, where 1 suggests strongly disagree and 6 suggests strongly agree. The interpretation of PEACE was the score ranging from 17 to 32 showed very negative attitude, 33 to 39 negative, 42 to 45 somewhat negative, 46 to 59 somewhat positive, and greater than 60 score was suggestive of positive attitude towards doping. This is the scale as shown. Procedure. A well-structured questionnaire with known reliability and validity was used, and Google form was prepared, which included consent of the participant, demographic details, and PEACE questionnaire. Online platforms like WhatsApp, Instagram, and mail IDs were used for the survey. Responses were collected, and Excel spreadsheet was prepared for proper data analysis, and MS Excel was used for the same. 92% of the total population agreed and gave their consent, while 7.5 disagreed to give the consent for the survey. After analyzing the eligibility criteria, my sample size was 61, where 2 were excluded. Data analysis was done through MS Excel sheet. Results. Out of total population, 54% were male, where 45% were female in my study. 62% results. The 62% sports physiotherapists were well aware and possess good knowledge regarding doping and do not promote its usage, while 38% still had a positive approach towards use of banned substances and promote use of performance-enhancing drugs, which is shown in the chart. 23% male and 15% female sports physiotherapists have lenient approach towards doping, while 34% male and 28% female sports physiotherapists are in support of negation towards usage of prohibited drugs. 60% sports physiotherapists agree that the risks related to doping are at higher side, while 30% sports physiotherapists still think that doping is an unavoidable part of sports. Discussion. Unlike the study conducted in 2020 by Wajiha et al. In her article, physiotherapists had a low level of general and specific knowledge on doping and lenient attitude, while in our study, higher percentage of physiotherapists were aware about doping. Also, from the results drawn, the majority of the sports physiotherapists are updated to media, while 56% think that media blows out of the topic the proportion and exaggerates the topic of doping. Although 48% sports physiotherapists are in favor of legalizing sports enhancement, which is a point to ponder, and a better strategies awareness programs be organized to change such beliefs. As this study included 61 participants, which is limitation, and was a conclusive of negative approach towards doping, a larger sample size may give a clearer perception. From the result obtained, still there is a need for better educational and awareness sessions to improve the knowledge, perception, beliefs, and attitude towards doping in sports physiotherapists. Conclusion: physiotherapists had a high level of negative attitude towards doping, but still fewer percentage supported usage of performance enhancement drug and had a positive approach towards it, which needs to be modified strategically with aggressive measures.
Thank you, Aditi. Now I call Dr.
I would like to
Syed.
end it. Thank you.
Good morning, sir.
Audible? Yeah.
Yes, sir.
Yeah. Aditi, I have a few questions for you. First of all, can you tell me what is the aim of your study?
So my aim of the study was to evaluate what are how is the attitude of the sports physiotherapists regarding doping. Like, are they positive or do they promote usage of performance enhancement drugs within the sports person, or are they in negation? Like, they don't promote, or they feel that is a negative, that gives a negative impact.
Yeah, but more than attitude, it is like once I would say few places you are confused between like knowledge about doping and opinion about like positive attitude about doping.
Yes,
so
sir.
looking like you're confused whether therapist is having knowledge about the doping substances or what is their opinion after knowing. So what is that? What exactly you
Yes,
want?
yes, sir. So in my scale, the 17-item scale, few questions were conclusive of attitude. So if a person is well aware and knows about it, only then he can comment that whether it is good or bad. So that is like, I have assumed that they have good knowledge, and hence they are reporting accordingly.
So once a person is having knowledge, so why you want to change their attitude?
So because fewer doping, doping substances have negative effects on longer usage, like steroids or something else. So if a physiotherapist is personally aware, he can stop, or he can advise those athletes that should not be these drugs are banned or should not be taken.
Okay. So you in your inclusion you have mentioned like you've taken the MPT sports physios and physiotherapists with 2 to 3 years of field experience.
Yes,
So
yes,
those
sir,
with field experience were like non-MPTs also?
So because there I have mentioned clinical therapists, because few of therapists might not have sports physiotherapy degree, but they have practical knowledge, like on field they have worked for 1, 2, 3 or 3 years. So they might be knowing about those drugs or doping. Hence, I have kept in the inclusion criteria that
No,
those who can, those who have.
Working, yes, but still I feel having a graduation degree and working in that field and doing a master's specialization in that field, obviously your knowledge and your attitude is different.
Yes,
like
yes,
when as a
totally.
PPT I am treating a ortho patient, and being an MPT ortho I am treating a patient, my approach will be totally different, my mindset will be totally different.
Yes, yes, agree, totally, sir, agree.
So and that performance that piece question, it is mainly for sports or it is like for general population?
So it is specifically for sports.
Specifically for sports, okay.
Yes.
And why you are taking convenient sampling? Any particular reason for that?
No, sir, because the topic of doping is as such that people don't want to participate or give their opinions regarding it. So I have included only those people, those who are like agree to participate in the study or like willing to give an opinion. Hence, no such criteria as such. But I think that. Yes, sir.
Okay. Thank you.
Thank you, sir.
Thank you, sir. Next, call upon Vijaya Teresa Demili from Surendra Institute of Physiotherapy and Rehabilitation, Andhra Pradesh.
Good morning, everyone. I'm Vijaya Teresa Demili. I'm from Swatantra Institute of Physiotherapy and Rehabilitation, Rajahmundry. My paper presentation on effectiveness of active cycle breathing technique and slow expression with glottis open and lateral posture on quality of life and functional capacity in subjects with bronchiectasis. Bronchiectasis is an illness characterized by the abnormal and irreversible dilation of the bronchus, and the destruction of the airway walls occurs due to infection and recurrent inflammation, resulting in impaired clearance with the accumulation of secretions in the affected area and bacterial coordination. In Asia, bronchiectasis prevalence rate is 7%, and in India, prevalence rate is 1.5 to 25% in men and 8.5 to 65% in women. Etiology of the bronchitis primary cause is idiopathic, and secondary causes are bacterial and fungal infections and cystic fibrosis and Mycobacterial tuberculosis. And main clinical features are cough, sputum production, narrowing airways, fatigue, chest pain, difficulty in breathing, and fever, wheeze, added breath sounds. And investigations of the bronchiectasis is chest X-ray, CT, MRI, sputum microscopy, snuffles, culture, PFT. And pharmacological management is bronchodilators, antibiotics, mucolytic agents. Surgical management is double lung transplantation, pulmonary lobectomy. And bronchiectasis had excessive secretion, so we use airway clearance techniques to clear the secretions like postural drainage, PEP, autogenic drainage, flutter, Ekpella device, chest physiotherapy. And my aim of the study is to find the effectiveness of active cyclo breathing technique and alcohol on quality of life and functional capacity. My objectives of the study is to find the effectiveness of active cyclo breathing technique in improving quality of life and increasing functional capacity on subjects with bronchiectasis, and to determine the effect of alcohol on improving quality of life and increasing functional capacity on subjects with bronchiectasis. And is to compare the effectiveness of active cyclo breathing technique and alcohol on improving quality of life and increasing functional capacity on subjects with bronchiectasis. And my study is a prospective study, and my study protocol was approved by ethical committee of GSL Medical College, and and my study population is clinically diagnosed bronchiectasis patients by pulmonologists, and my study was conducted on Department of Respiratory Medicine, JSL Medical College and General Hospital, Rajmahendravaram, Andhra Pradesh, India. And my study was conducted during the period of July 2022 to June 2021, and it's a systemic sampling, and I used 4 weeks protocol, include active cyclo breathing technique and alcohol, and my sample size is 120 subjects were included, and 60 subjects were willing to participate, and then 30 subjects were included in each group, active cyclo breathing technique and alcohol group. And I used materials like inch tape, consent form, data collection sheet, and SF36 questionnaire. And I include patients with 45 to 75 years, bronchiectasis patients, stable patients, and no contraindication for physiotherapy management. Exclusion criteria: rib fractures, osteoporosis, or pneumothorax, and COVID-19 patients also excluded. And my outcomes are like SF36 questionnaire and 6 months walk test. And in my procedure, I include active cyclo breathing technique. In this, we have three exercises like deep breathing exercise, breath control, and huffing. And deep breathing exercise will help to unstick the secretions, and breath control will mobilize the secretion to the proximal airways, and huffing will clear the secretions. In alcohol, it can be performed in lateral decubitus position. In this patient, subject is instructed to perform inspiration and slow expiration with open glottis. At the same time, therapist apply the infralateral abdominal compression and thoracic compression, and perform the active technique. And in this lateral position, 2 pillows will be used. One pillow is placed behind the right knee, and another pillow placed at the abdomen. And again the results like these in active cyclo breathing technique and alcohol, we have a significant improvements on both in a 6 months walk test and SF36 questionnaire. And my total 120 subjects were eligibility, and 60 subjects were screened, and all the 60 subjects I randomized into 30 in each group. In 30 subjects participated in Group A, completed their training, and 29 subjects were completed their training in Group B. And I have significant improvements in both SF 6 months walk test and SF36 questionnaire. My SF36 questionnaire components are physical functioning, limitation due to physical problem, limitation due to emotional problem, energy, emotional well-being, social functioning, pain, and general health. And both alcohol and active cyclo breathing technique, I have a significant improvements, and it's like a p-value is less than 0.00. And my discussion of this study is to like I mostly like active cyclo breathing technique have shown statistical significant difference from a pre-test to post-test, and these thoracic expansion exercise and breath holding are like provides optimal filling of obligatory airways, and it shown improvement on the quality of life and functional capacity and bronchiectasis. And ACBT is mainly concentrated on standardizing the respiratory pattern and increasing airway clearance and decreasing work of breathing. So along this, it helps to improve quality of life and reducing breathlessness, and it improves functional capacity. When it comes to alcohol, it improves lung volumes from functional residual capacity to residual capacity. Then it's a slow expression with open glots, improve perfusion ratios, and alcohol it's performed in lateral decubited position so that it can reach the finest clearance in the inferior lateral lung. And finally, the cough takes away the secretions through the mouth, and then the therapeutic varies like without it, but only using inspiratory and expiratory flows. Technique shows improvement in subjects. So when comparison between these both groups, it shows significant improvement in post values. And when comparison between active cycle breathing technique and alcohol is shown more significant values effective than active cycle breathing technique. So that study provides alcohol techniques like shows the effect of improving functional capacity and quality of life when lateral posture avoids gravitational pull, and then the slow expression helps to clear the secretions. So I recommended alcohol to the patients with bronchiectasis, so it can achieve significant benefits by using alcohol technique. And my conclusion of the present study is 4 weeks of intervention of active cyclo breathing technique and alcohol training were shown significant improvements on functional capacity and quality of life. However, more percentage of improvement was found in subjects received alcohol training when compared to active cyclo breathing technique. From findings of the present study, it can be recommended that alcohol is suitable adjustment to conventional physiotherapy treatment technique in subjects with bronchiectasis. Thank you, everyone.
Thank you, Vijaya. Now I call Dr. Syed Subaisa to ask questions.
Good morning, Vijaya. Am I audible to you?
Yes, sir. Good morning.
Vijaya, what is systematic sampling? How you did the sampling for this thing? Can you tell me?
Yes, sir. Yes, sir. I took the subjects like systematically divided into like 2 groups there. I used computerized tables.
Computerized tables.
Yes, sir.
Okay. And did you follow? Do you know what is CONSORT guidelines? CONSORT, CONSORT guidelines? You're not aware. Okay. You didn't mention level of significance of your study. Results.
Yes, sir. Less than 0.006. I have significant improvements in both active cyclo breathing technique and alcohol, sir.
In which group? Group A or B?
I have significant difference between both groups, sir, but compared to alcohol is more significant than active cyclo breathing.
So on what basis you can say? Means there should be some data, like it should be whether it was clinically significant or statistically significant, or it was both.
Statistically significant.
So what was the value?
My pretest values.
Method of analysis you have used? Which test or which way you have did the data analysis?
Within the group, independent t-tester, between the groups, paid t-tester used.
Okay. Do you know what are the different reference formats, Vijaya?
Sir?
Like Vancouver is there.
Yes, sir.
So I think the organizers have already asked previous candidate also. The references in presentation should be in APA format, as per your guidance. I didn't feel even yours in the previous things. Okay, thank you.
Thank you, sir. Next, call upon Nikita Saraf from MGM Institute of Physiotherapy, Maharashtra.
Good morning, one and all. The title of my paper presentation is Caregiver Perspectives on Symptoms Management in Palliative Care for Terminally Ill Patients, a Qualitative Descriptive Study. Palliative therapy is an active care for patients whose illness has such nature that is not responding to the curative treatment. Caregivers are the most imperative part of the palliative care structure, and it is apparent for them to support emotionally, physically, psychologically, and socially. And the main area of burden on caregivers is the management of end of life pain. Palliative care comes under an umbrella term hospice services. Other services are cancer care, post-operative care, respite care, and bedridden patients. As India is undergoing a demographic transition from a population with high fertility, high birth rate, and higher death to a population with low fertility, low birth, and death rates. Henceforth, the population of elderly in India is increasing. Also, the elderly population has high rates of illiteracy, and they are economically dependent fully on others. Global burden of diseases 2017 estimated a total of 9 million deaths, and around 59% of them was estimated to be elderly population. As an individual primary caregiver, greater awareness about healthcare issues of the elderly is needed. Training and continuous education about approach and management of their common problems is much needed. Adding newer skills like psychological counseling and behavioral counseling for hygiene, pain management, and most importantly, palliative care management is needed. We can also use telecommunication and web-based support for primary caregivers for training and consulting individual patients. The study design of this study is qualitative descriptive study. Study setting a palliative care center located in Aurangabad. Study population caregiver. Sample size was 12 and duration was from Jan 2021 to June 2021. Simple random method of sampling was used. Ethical approval was taken and informed consent was taken. Aim of this study was to elicit the challenges, needs, salient concerns faced by the caregivers in palliative care centers. Inclusion criteria was caregivers working in a local palliative care centers, and exclusion criteria was caregivers having less than 5 years of work experience. Caregivers were selected from a PCC in Aurangabad. 2 out of 4 departments of PCC agreed to participate. In procedure, interview sessions were taken face-to-face and video conference because of COVID-19 lockdown. All the interviews were conducted by the lead researcher and all sessions were noted simultaneously. Each interview lasted for around 30 to 40 minutes, and each caregiver gave 2 interviews within a study span. All the interviews were conducted at caregivers' workplace and scheduled around the availability and wherever possible. Data analysis was done using grounded theory strategies. You can see the result in this table with the gender and years of experience percentage. A total of 12 mostly experienced caregivers gave the interviews, and we have seen 5 characteristics identified in our analysis. First one, working for God. Second one, the battle for information. Next one, working with minimum funds, multiple patient barriers, and prioritizing works. The caregivers felt when they are working with patients as if they are working for God, and they find it as a great opportunity to connect with God. But at the same time, they also desired the information for up-to-date and comprehensive knowledge about the community-based activity and how to tackle the medical emergencies. As they had no education, they desired a formal education on how to tackle the emergencies such as depression, anxiety, fear of falls, and anemia, etc. Working with minimum funds, caregivers stated that the number of beds is still the same, but the number of patients is increasing every day. So they have to manage with the minimum funds and to run the institution. There were also multiple patient barriers. Prioritizing work was one of the most challenging difficulties stated by the caregivers. Even though all the caregivers had decided to devote their lives to take care of the terminally ill patients, they still desired access to emotional support and knowledge regarding the course of diseases. In the implementation strategy, we have thought that hospitals should arrange more meetups where the community providers working in NGOs along with healthcare workers and caregivers should meet, and where caregivers can ask the questions and create connections with the healthcare workers. Next suggestion was to increase the number of staff because the current ratio of caregiver to patient is 1:10. This is the image of the caregiver taking care of a terminally ill patient. In our conclusion, all participants showed interest and openness to multidisciplinary approaches for addressing these needs. Our study results can be used to develop standard indicators that precisely mirror the point of view from a caregiver perspective. This is called checklist for qualitative study. Discussion guide for the caregiver interviews. And this is the questionnaire developed by the authors having three main areas. First one was exploring beliefs about palliative care, exploring the needs of caregivers, and third one was key approaches, barriers, and challenges. These are the references. Thank you.
Thank you, Nikita. Now I call Dr. Syed Subay sir to ask question.
Good morning, Nikita. Am I audible? Nikita, unmute yourself. Please unmute yourself.
Yes, sir. Yes, sir. You're audible. Yes. Good morning, sir. Yes, you are audible.
Very good presentation, Nikita. Means that
Thank
slides.
you, sir.
Very good topic. I have few questions for you. How you have calculated the sample, Nikita?
Sir, in that institution, in the palliative care center, there were total 12 caregivers.
Okay.
So it was basically universal sample size as wording. That's why simple random method was used. So all the total 12 caregivers were taken in this procedure.
But don't you think like for a survey, 12 sample size is very, very, very low? It's a survey, na? It's a kind of survey. Hello? Hello?
Nikita?
I think there is a network issue with her.
Yes, sir. Shall I call next?
Yes, sir, it is. But again, this is not. Okay. Hello, sir, am I audible?
Yeah, Nikita, sorry, I think there
Yes,
was a
sir.
network with you.
Okay. Now I have come in the network area.
Yeah,
So actually, this is a quality to descriptive study. The survey design is not used here. It is only used to describe a particular result. What are their challenges, their needs, their perspective about caregiving. So we have only formulated a questionnaire and described their problems and needs.
So did you validate this questionnaire?
Yes, sir. The questionnaire was given to 3 departmental HODs of the college and 2 assistant professors and associate professors. So they have reviewed the questions and they have categorized the data of the content in 5 categories: good, excellent, acceptable, poor, and not acceptable. So by using the Cronbach's alpha value, the value for the questionnaire, the items came under almost 0.73, which is an acceptable category.
Okay. So can you tell me what is the means as a physiotherapist, what is the perspective of the study means? It looking more of the humanity and emotional aspect.
No, sir. Actually, we were posted in this Mother Teresa Charitable Trust, and the caregivers there are facing a tremendous amount of emotional instability, depression, anxiety, and stress. And as a physiotherapist, I am a community physiotherapist from the college. So as a community physiotherapist, I thought along with physical health and physical pain, mental health of the people is also important. As we were treating the patients, so the caregivers also faced many problems. So along with this study, we have also started sessions for caregivers also. So before treating patients, we are treating and taking sessions of caregivers, including the breathing exercises, as we are facing the pandemic. And along with that, to improve their mental health, yoga is taken and aerobic activities. And once in a week, dancing session is also taken for the caregivers as well as the patients.
Okay, thank you. Good, very good. Thank you.
Thank you, sir.
Thank you, sir. Next call upon Ohalada from Swandra Institute of Physiotherapy and Rehabilitation, Andhra Pradesh.
Good morning, everyone. Myself, Uhalata, MPT second year, Neurology. My paper presentation is on effectiveness of mobile-based virtual reality training on improving balance in elderly population. Background. Balance can be defined as controlling the body center of mass within the base of support during static and dynamic situation. It mainly depends upon the coordinated and integrated action of visual, somatosensory, and vestibular systems. World Health Organization states that it is about 28 to 35% of above age to 65 experience falls every year. With increasing age, it increases. whereas in India, 14 to 53%, mainly affecting females. Falls in may result in loss of autonomy, dependence, confusion, depression, and immobilization, which comes under post-fall syndrome. Virtual reality has promising effect on improving balance in stroke, Parkinson's, multiple sclerosis, cerebral palsy, and cognitive decline patients. Virtual reality increased attention from researchers and clinicians because of its potential for fall prevention, balance rehabilitation. Virtual reality can be described in terms of interaction, immersion, and imagination. Many studies were conducted on the effect of virtual reality training on balance, but very few were connected on proving on effect of mobile-based virtual reality training on balance rehabilitation in elderly people. Objective: to determine the effectiveness of mobile-based virtual reality training, to determine the effectiveness of conventional balance training, to compare the effectiveness of mobile-based virtual reality training along with conventional balance training and only conventional balance training alone. Next, methodology, quasi-experimental study design, ethical committee of GSL Medical College approved ethical clearance, study population, elderly subjects with fall risk, study setting, outpatient department of physiotherapy and medical college, physiotherapy GSL Medical College, study duration, July 2022, June 2021. Sampling method, systematic random sampling. The sample size of 120 subjects were screened and 103 subjects were recruited. Inclusion, 65 to 80 years aged older adults, subjects with work balance scale of 40 and below, we at least walk 10 meters without walking aids, able to stand independently for 90 seconds, having adequate hearing and vision, ability to perform ideals. Exclusion, history of stroke, peripheral neuropathy, rheumatic and orthopedic diseases, elderly people using dependent ambulation, presence of pacemaker, serious visual or hearing impairments, previous lower limb surgeries. Outcome measures, work balance scale and timed up and go test were used as outcome measures. The work balance scale consists of 14 item scale in which it increases from sitting to standing and single leg standing. It advances from there. Patients were rated on 5-point scale basing on their performance. The cutoff score is 45 out of 56. Timed up and go test. It was 3 meters walking test in which the person walks in 3 meters on his own pace and the amount of time has been recorded. Procedure in 103% in 103 subjects, 51 subjects were taken in Group A and 52 subjects were taken in Group B. Group A consists of conventional balance training along with virtual balance training, and only Group B has conventional balance training. In virtual balance training, Incel VR game is being used, which is an app. It consists in which the longitudinal structure, the subject moves on a longitudinal structure towards the nucleus of the cell. The subject has to tilt his head to attain proteins and speed pads, which adds more energy and to escape from the virus. And the obstacles that slows down the speed of the journey in case of touching the virus are the automatic feedback warns the subject to move safe. Group B, conventional balance training consists of only static and dynamic exercises like walking, standing still, and stepping sideways, walk with arm swing, hip extension, abduction, etc. As a result, at the end of the session, one subject from Group A and 2 subjects from Group B were dropped out. Results. Results states that work balance scale and timed up and go test both were improved in Group A and Group B subjects. But whereas in Group A, the improvement of is more compared to Group B. So they are highly significant compared to Group B. Hence, it can be proved that virtual reality training has an additive effect when compared to only conventional balance training alone. Discussion. The main objective of the study is a low-cost, easy implementation of treatment program by using mobile devices. Because of its small size, lightweight, they were portable without any problems regarding the person's surroundings. Next, VR-based intervention is more mentally and physically challenging compared to rehabilitation exercises because of its demand on cognition, organization, execution, synchronized emotions. They activate neural structures and circuits that transfer immediate game effects to long-term effects. It has special importance for visual displays. Moreover, other reference cannot be overlooked, which includes a vestibular system that senses head movements. Visual stimuli along with head movements are hypothesized to be used in training for balance control. In our present study, we used HMD VR, head-mounted displays, virtual reality with smartphone enclosed in it. The game Incel VR used in our study is not specifically designed for balance training, but the game program mainly targets the head movements which has greater impact on balance training by reweighting the sensory inputs. In this game, the difficulty level increases with speed. Specific tasks like hitting proteins and avoiding the viruses make it more interesting than continuous repetition of the constant movements. A VRT is a playful intervention. It encourages the participant to involve in balanced rehabilitation. The study can be helpful in increasing the awareness for physiotherapists to broaden their scope of rehabilitative care in elderly population. And finally concluded that mobile-based virtual reality training has additional effect on balance, can be used as an agent to improve the balance in elderly population. Thank you.
Thank you, Lata. Now I call Dr. Saya Subhay sir to ask question.
Good morning.
Good morning, sir.
Am I audible to you?
Yes, sir.
Yeah, very nice study. I have
Thank you,
few
sir.
questions. See, virtual reality VRT is a very huge term. Okay, it's a very vast term. So I want to know what exactly you use in virtual reality training for your patients.
I used HMD VR, sir, head-mounted display, sir. In that we enclosed a mobile, sir, that was playing a game, which I took a reference from one kind of journal, like it's an Incel VR game, sir. It consists of a longitudinal structure, like we are standing on one thing, and it was moving like this. Our journey is towards our goal is to reach the nucleus of the cell. The game itself is about the biology, sir. Its main objective is to move towards the nucleus, sir. While moving towards it, we encounter some kind of viruses and some kind of proteins and some kind of pads, sir. The viruses slows our journey, sir. Whereas the proteins and speed pads makes us to move faster, and it encourages us, sir. And this kind of a feedback can
like
make
temple run game. You are saying like that?
Yes, sir. Yes, sir. Yes, sir. But
you could have added some pictures of your game or some preview of that game into your presentation. That could
yes,
have given
sir.
a better idea of what you're doing.
Okay, sir.
Yeah, and one more question: the duration of study was from July 2022.
1 year, sir. Study duration 2021.
103 participants. What was the age group you have mentioned?
65 to 80, sir. Elderly subjects.
Into this.
Sir, I visited one outpatient like a rehab center, sir, like old age people center, sir. There I took some participants, sir.
Okay. No, it's a 103 the sample size. All 103 from that place.
Yes, sir. It was a huge center in Rajmundry, sir.
Okay. So you could have added few pictures, na? Did all
yes,
COVID
sir,
protocol you followed during that? They allowed
yes,
you?
Sir, yes, sir. Yes, sir. Yes, sir.
Okay.
Actually, I had some pictures, sir, but it was not mentioned in that name checklist, sir. So I
If
haven't.
you don't have any presentation, it's a very good study. But if you
yes, sir,
added few pictures in that game description, na, like some
yes, sir, but actually it was not mentioned, sir. So I haven't done it, sir.
Yeah. Okay. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Next call upon M. K. Manikanta from Surendra Institute of Physiotherapy and Rehabilitation, Andhra Pradesh.
Good morning, respected dignitaries. Myself, K. Manikanta, doing MPT cardio second year in GSL Medical of Rajmundry. My paper presentation is on effectiveness of Botega breathing technique versus breathing returning on peak expiratory flow rate and quality of life in subjects with bronchial asthma. Introduction. Asthma. It is defined as a chronic inflammatory disorder of airways in which many cells and cellular elements play a role in the chronic inflammation and disease associated with the airway hyperresponsiveness that leads to recurrent episodes of wheezing, breathlessness, and coughing, particularly at night or early morning. The prevalence of asthma in the world, it is estimated at 334 million people of all ages and estimated at 225 million people live with asthma. In 2015, it is estimated that the prevalence of asthma in the world has increased to reach 400 million people. There are many causes of asthma, include genetic, environmental factors, exposure to allergens, occupation irritant, tobacco smoke, respiratory infection, etc. Strong emotional expression, chemical irritant drugs. The characteristic features of asthma are leukocyte infiltration, epithelial sloughing, basement membrane thickening, edema, hyperplasia of mucous-secreting glands, hypertrophy of bronchial muscles. There are two types of asthma, atopic and non-atopic. Atopic patients have higher concentration of exhaled nitric oxide compared with non-atopic patients. Asthma that has exhaled nitric oxide concentration. Atopic patients with asthma are more hyperresponsive to inhaled adenosine 5-monophosphate than non-atopic patients with asthma. The diagnosis of asthma. requires a complete medical history and physical examination along with assessing lung functions. However, sometimes additional tests are needed to confirm the diagnosis of asthma to rule out other diseases that may present with symptoms that mimic asthma. Objectives: to assess the effectiveness of Bottiga breathing technique on peak expiratory flow rate and quality of life in subjects with bronchial asthma, and also assess the effectiveness of breathing retaining on peak expiratory flow rate and quality of life in subjects with bronchial asthma, and also to compare the effectiveness of both techniques in subjects with bronchial asthma. Methodology: the study was designed as prospective study design, and ethical clearance was and informed consent. The study protocol was approved by Ethical Committee of GSL Medical College, Rajahmundry. Study setting at Department of Physiotherapy, GSL General Hospital, Rajahmundry. Study duration: the study was conducted during the period between July 2020 to June 2021. The treatment duration was 6 weeks of training program, which includes Bottiga breathing technique and breathing retaining. Group A received Bottiga breathing technique for 4 days a week for 6 weeks. Group B received breathing retaining 4 days a week for 6 weeks. The sample size was 108 subjects with bronchial asthma were screened. In those, 78 subjects were recruited who are willing to participate in the study. All the eligible participants were consecutively randomized to either Bottiga breathing technique or breathing retaining, with 39 in one group and 39 in another group. The type of sampling was used by simple random sampling. Inclusion criteria: the patient diagnosed with asthma by respiratory physician. Both male and female subjects are included. Age group between 25 to 65 years. Patient taking inhaled beta-2 agonist at least twice a week. Regular inhaled corticosteroid. These are the inclusion criteria, and the exclusion criteria are unstable medical condition or uncovered systemic disease, history of serious condition or disease such as cancer, disturbance of awareness or COVID-19 positive patient, and cognitive impairment. The outcome measures are peak expiratory flow rate and quality of life, except quality of life questionnaire. The peak expiratory flow rate is the maximum expiratory flow rate after a hard inspiration and is correlated with the forced expiratory volume in 1 second. As the PFR values objectively indicate airway obstruction, its measurement can help monitor the individual level fluctuation in lung function of patients with asthma. The peak expiratory flow rates are regularly ordered into 3 zones: green zone, yellow zone, red zone. Green zone consists of 80 to 100%. It is usually or normal peak flow reading are clear. It is under good control. Yellow zone consists of 50 to 79% of usual or normal peak flow reading indicates it may mean respiratory airways are narrowing up and additional medication may be required. Red zone, it is less than 50%. This would usually involve contacting doctor or hospital. It indicates a medical emergency. Severe airway narrowing may be occurring and immediate action needed to be taken. Measurement of SF quality of life questionnaire. The SF item short form health survey questionnaire is the most popular instrument for assessing health related quality of life. It is self-administered questionnaire that contains this item, which takes about 5 minutes to complete, and it measures health on 8 multi-item scale. For each scale, item scores coded somewhat transformed onto a scale from 0 to 100. This questionnaire allows the patient to self-assess psychic, physiological, and social aspects of his or her quality of life. There are 2 distinct components measured by SF questionnaire. There are physical dimensions measured by physical component survey and mental component summary. Bottiga breathing technique consists of a series of exercises in which subjects reduce the depth and frequency of respiration. Step 1, the control-based breathing test. Ask the patient to sit in an upright chair and adopt a good posture. Relax the shoulder and rest lower back against the back of the chair. Ask the subject not to change breathing force before taking his control breath. Take a small breath in 2 seconds and a small breath out 3 seconds. Ask the subject to hold his nose on out the breath with empty lungs but not too empty. Holding his nose is necessary to prevent air entering into the airways. Count how many seconds that can be comfortably last before the need to breathe in again. Ask the subject to hold his breath until feeling the first need to breathe in. Release the nose and breathe through it. Inform the subject that his first intakes of breath after the control burst should be no greater than his breath prior to taking measurement. The subject should not hold his breath for not too long, as this may cause him to take a big breath after measuring control burst. Step 2, shallow breathing sit-up straight. Monitor the amount of air flowing through nostril by placing finger under patient nose in a horizontal position. Finger should lie just above the oblique, close enough in the nostril so the subject can feel the airflow, but not so close that the airflow is blocked. Now breathe slightly into the tip of the nostril. Breathe in a flicker of air with each breath. Step 3, putting it together, take control burst. Reduce the breathing for 4 minutes, wait 2 minutes and take control burst. Reduce the breathing for 4 minutes and wait 2 minutes and take control burst. Breathing retaining technique. These specific techniques, there are 3 specific techniques: diaphragmatic breathing and asthma guided specific imaginary and progressive muscle relaxation that were developed by others. Discussion. The results of study showed significant difference between Bottiga breathing technique and breathing retaining in subjects with bronchial asthma who received 6 weeks of intervention. So the finding of the study suggests that Bottiga breathing technique and breathing retaining is more effective in reducing bronchial asthma, but Bottiga breathing technique is superior to breathing retaining because it reduces the severity and improved ability to control the asthma. Conclusion. The present study concluded that after 6 weeks of intervention, both groups showed significant improvement in PGS flow rate and increase in quality of life in subjects with bronchial asthma. However, Buteyko breathing technique is more effective when compared to breathing training. Thus, this study concludes that Buteyko breathing is a useful agent in bronchial asthma. Thank you, everyone.
Thank you, Manikanta. Now I call Dr. Syed Zubai sir to ask question.
Good morning.
Good morning, sir.
Good morning. Manikanta was very speedy presentation because I could capture anything. It was slide was passed. Okay. Can you tell the type of study? Type of study. You are mentioning
Sir, I'm traveling from Rajahmundry. There is an.
Am I audible to you? Am I audible to you? Manikanta, am I audible to you? Yeah. Can you tell me how you excluded COVID positive? What was the criteria? Manikanta?
Sir, yes, sir.
How you excluded COVID positive patient? What was the criteria?
Sir, the inclusion.
Yeah, means you have asked them for their COVID testing, or you have done their COVID testing. What was the how you were excluded? Hello. I think he's traveling.
Can I ask next candidate?
Yeah. I think we'll go for next. We'll see if he's available later.
Next, last candidate. Next call upon Namrata from Surendra Institute of Physiotherapy and Rehabilitation, Andhra Pradesh.
So good morning, respected dignitaries. Today my paper presentation on effectiveness of transcutaneous electrical nerve stimulation and low-level laser therapy on hemiplegic shoulder pain, a comparative study. Myself, D. Namrata, studying MPT second year urology in Rajahmundry GSL General Hospital. So introduction. Hemiplegic shoulder pain is present at rest during passive or active movement on hemiplegic side after stroke with no direct relation to trauma or injury. It affects daily activities, poor recovery of arm function, quality of life, and can increase the duration of hospital stay. And the incidence ranges from 53 to 84%. Shoulder pain after stroke is not limited to single pathology. Multiple pathologies contribute to it. Muscle weakness after stroke is believed to the primary cause, and other factors such as subluxation, weakness, rotator cuff tear, and tendinitis. As shoulder muscles can't contract effectively against the gravity and external forces during the movement, the humeral head can't be held in a proper position. Soft tissues around the shoulder may gradually stretch and tone, resulting in hemiplegic shoulder pain. Careful history taking and musculoskeletal examination may aid in diagnosis the cause of hemiplegic shoulder pain. Transcutaneous electrical nerve stimulation is used in patients with hemiplegic shoulder pain and found remarkable reduction in pain and improved range of motion. Both these modalities are shown to be effective in treatment of musculoskeletal pathologies. Previous studies emphasized on the role of TENS and laser in hemiplegic shoulder pain, but limited studies compared the effectiveness of these two modalities on HSP. So the aim of the study is to compare the low-level laser therapy and transcutaneous electrical nerve stimulation in subjects with hemiplegic shoulder pain. Objectives: to determine the effectiveness of transcutaneous electrical nerve stimulation on pain and upper limb function, to determine the effect of low-level laser therapy on upper limb function, and to compare the effect of transcutaneous electrical nerve stimulation and low-level laser therapy in hemiplegic shoulder pain. Methodology: study design, prospective, study setting, Department of Physiotherapy, GSL General Hospital, study duration 1 year, treatment duration 3 to 4 days per week, sample size 6, and type of sampling, purposive sampling. Inclusion criteria: age between 50 to 75 years, ischemic or hemorrhagic stroke diagnosed by the neurologist, pain on the hemiplegic shoulder pain, adequate communication abilities. Exclusion criteria: unable unstable medical condition, or uncontrolled systemic disease, skin problems, wounds or infections, history of serious conditions such as cancer, history of intra-articular steroids, administration of non-steroidal anti-inflammatory drugs. Outcomes include Mayer assessment for upper limb motor function and shoulder pain disability index for pain and disability. Procedure. The subjects, after meeting the inclusion criteria, as diagnosed into two groups, and the pre-test includes of FMA and SPADI. All the subjects will receive the rehabilitation program and the pre-measures and post-measure. All the subjects undergo a treatment protocol of 3 to 4 days per week for 4 weeks duration. After the treatment duration, post-test test will be measured. Treatment protocol. Low-level laser therapy. The subjects required on a seated comfortable chair. Low-level laser therapy was applied around the affected shoulder, and the wavelength of 810 mm is used, and the most painful joints on the shoulder are found on clinical examination. Laser was held on a perpendicular to the body surface with contact to the skin without pressure, wearing the appropriate spectacles to protect the eyes against the laser. The treatment lasted for 4 times a week for 4 weeks. The treatment session for 20 minutes. Transcutaneous electrical nerve stimulation. Transcutaneous electrical nerve stimulation with a frequency of 100 Hz and pulse width of 100 Hz is used. The surface electrodes were placed on the motor points of supraspinatus and posterior deltoid fibers to postulate the supraspinatus and deltoid shoulder coordinate to stabilize the humerus. Each treatment session of TENS also lasted for about 20 minutes. The conventional physiotherapy includes of sensory motor training, manual therapy, stretching, muscular strengthening, and patient education. And the results. A total of 70 subjects were screened for eligibility. Among 66 subjects met the inclusion criteria. The 66 subjects underwent baseline assessment and were randomized into 2 groups. The present study suggests that low-level laser therapy is more effective in reducing hemiplegic shoulder pain. Low-level laser therapy has short, medium, long-term effects, and it has the medium effects decreases the local edema and inflammation, and the long-term effects includes of resulting improving the tissue healing. So findings of the study suggests that low-level laser therapy and TENS are effective in reducing hemiplegic shoulder pain, but low-level laser therapy found to be effective and has biomechanical changes in the cell, resulting in the first low-level laser therapy is the first treatment of choice in hemiplegic shoulder pain. Thank you.
Thank you, Ramnata. Now I call Dr. Syed Zubai sir to ask question.
Hello, am I audible, ma'am?
Yes, sir.
Yeah. So presenter is there. I think Simran was the last, no, ma'am?
Yes, sir.
Yeah. Am I audible to you, Simran? Hello. Who was there, ma'am, last minute? Namrata.
Yes, sir.
Okay. Am I audible to you?
Namrata, are you there? Namrata, unmute your phone. Namrata, unmute yourself.
Ma'am, as a host, you can unmute, I think.
Namrata, your audio is in mute. You have to unmute your audio.
I think as a host, you can unmute her, I think.
Yeah, just we are going for that. Sir,
Hello. Namrata, kindly unmute yourself. You need to unmute yourself.
sir, from our side, we have asked her to unmute, but I think there is
They are not connected with their audio devices, ma'am.
Yes, sir. Yes, sir. While joining itself, I think they didn't join with their audio device.
Audio device. That's why it's trouble.
Yes, sir. Ma, you can, Namrata, you can type the answer in the chat box also. Until you're connected with the audio, you can type your answer in the chat box also.
Okay, we'll do that. Okay, ma'am.
Yes, sir. They have said okay, ma'am. So we can put forward our first question.
Yeah.
Namrata, can you able to view the question which sir has asked? Sarah asked, why lasers resistance?
Yeah, why you have used laser versus TENS in hemiplegic shoulder? My question to you, Namrata.
So she has answered hemiplegic shoulder pain is neurological pain. Laser.
No, that is my question, ma'am. That is my question again.
Okay,
she has answered. I think
laser is more effective because it reaches cell level directly.
So you already come to the conclusion. Then why you have done the study? You already know laser is more effective. You already know. You are only saying laser is more. It's a neurologic pain, Namrata. My question is, and you are checking your functionality, upper limb functionality, range of motion. So obviously laser is having only pain relieving effect, while your TENS is having little bit like muscle contraction, and also it may contribute little bit to strengthening also, I can understand. But how laser is contributing to range of motion and upper limb function just by reducing pain?
Pain is reduced, where the structures in the hemiplegic shoulder are involved, that can lead to the increase in the range of motion and improve in the upper limb function, sir.
Okay, and you have mentioned that laser is reducing, laser effect is long term compared to TENS effect. So what is your follow-up duration, Stradika?
Sir, pardon, I couldn't understand.
One of your
sir.
slide, you have mentioned that laser is having a long-term effect compared to TENS.
Yes, sir.
So what was your follow-up? How long you have did the follow-up with the patient?
Sir, actually, I have not done any follow-up, sir. But during the study period, I have observed that laser is more effective due to the
okay.
Sir, I have only observed the immediate effects, sir.
But you mentioned that long-term effect, laser is more effective. Okay. Okay. And you have told biomechanical changes in cell by laser. Can you tell me how biomechanical changes in cell taking?
When the laser light enters into cells, where the mitochondria absorbs the oxygen and photon.
Yes. That is the mechanism of action of laser in terms of your hemiplegic shoulder, I am asking.
Same thing happens when the laser light is applied to the hemiplegic shoulder pain, sir. It creates the tissue healing, sir, tissue repair.
why you chosen low level laser therapy? Was it class 3A, class 3B, class 2? Which laser you used? Low level, any particular laser?
Laser, sir. GA.
Class 2, class 3, 3B, or class 4?
So no. Actually, I have used the therapeutic laser which is available in the GSL college, sir.
Which one is available, ma? That's what I'm asking. Is it class 2, class 3A, 3B, class 4? Because all three are having different effect.
Yes, sir.
Okay. Thank you. Thank you.
Thank you, Zubair sir. Our principal want to thank you, sir, for the time you have given for us for past 2 days. Video.
Thank you, Jubair, being with us for the long time.
Yes, sir. Thank you so much, sir, for giving me the opportunity.
Yeah, thank you, Jubair.
It was a wonderful platform, and thank you, everyone. It was a wonderful session, good studies. But the certain suggestions I would like to give, sir, 2 minutes, if I can say something.
Yeah, definitely.
To the participants, I would like to say, your PG student, when you are doing a paper presentation, so don't think that we are here to point out your mistakes or something. See, you're presenting your study, so you have to make understand the person in your presentation that what exactly you have done. Okay, so we are asking questions only to those points which we have not understood. So participants should be like more into that thing. Most of the thing, it is going like a news reading. When organizers have clearly mentioned what type it should be, how much font should be, but I have seen hardly anybody is following that guidelines given by the organizers. So participants should be take care those things in future. And wonderful organization, sir. Very good 3 days. It was really good for students also.
Yes, Jubair, thank you. That
Thank
we
you for
will.
giving me the opportunity. Yes, sir.
Yeah, we will take the message to our team. Then we will do it all those things. Jubair. Thank you, Jubair.
Yeah, thank you, sir. Thank you.
We are thankful to Dr. Syed Zubair sir to be a part of this session. We are grateful for your valuable time that we get your share with you, sir. Thank you, sir. By this, we have come to the end of the third session of PG paper presentation. After 10 minutes, we will be having our PhD scholars and faculty's paper presentation. Then we are looking forward your valuable feedback. The feedback form will be uploaded to the www.ppgphysiocon.com webpage at the time of the 3rd PM. After the submission of feedback form only, you will be receiving the conference certificate. We will announce the winner of paper presentation at the time of validation function. I kindly request you all delegates to join the validation function on today 4 p.m. The link will be shared via WhatsApp group. Thank you, everyone.
A warm greeting to one and all present here. On behalf of PPG PHYSIOCON 2K21, organized by PPG College of Physiotherapy, we heartily welcome you all for the paper presentation. I am Mrs. Bindya, Assistant Professor PPG College of Physiotherapy. I am very glad to host this event. It's our great pleasure to welcome Dr. M. Manoj Abraham, PhD in Physiotherapy, Principal of KG College of Physiotherapy, Coimbatore. We are honored to have you as a panel member, sir. Before going to start our event, all delegates kindly live during your allotted slots and do check your network connectivity. Now, without any further delay, let's begin our first session of paper presentation. I would like to welcome our first candidate, Dr. Madhumati K., Wales Institute of Science, Technology and Advanced Science, Chennai, to present her paper.
Warm greetings. This is Mrs. Madhumati K., MPT, PhD, Assistant Professor, Research Scholar, S4PT, Vistas. So the topic is the novel gaming technology in neurological rehabilitation, cross-section analysis of parents' attitude. So we are going to discuss on what basis the game is developed and what is the attitude of the parents. So we are going to discuss depending upon the results. In rehabilitation setting, the video game have an impact on the cognition and motor domain. The cerebral palsy children have problems in perception, reasoning, and memory. All these are related to the mathematical ability. Due to motor problems, the CP children engagement in schools are affected. National Education Policy 2020 emphasizes on education for all and focusing on yearly literacy and numeracy. In recent years, the video games have gained its access to the rehabilitation settings and educational systems. The acceptance of the novel game in rehabilitation by the parents are important to apply it for the children. The parents are in a dilemma whether the video game can be beneficial and they are more concerned about the screen time. Digital gameplay has become a mainstream activity. Today, parents are avid gamers by themselves. The majority of the parents were grown up where digital games are not very famous. Parents should need to understand the style and gameplay development and guide their children in selecting the educational digital games. So this structured spatial skill educational video game were structured and designed in such a way that it serves the educational purpose. It includes maze, puzzle, mental rotation, matching shapes, identifying objects, and spatial games. 3 levels are there. Its personalized ID and password is given. And the children can play 40 minutes in a day, 3 times in a week, and game will be automatically logged after 24 play sessions. The game sessions are monitored from the remote server. The game features also includes hints, instructions, scoring method, mild colors and sound, cartoon characters, science tree, motivation pop-ups, mind map, game flow, and scoring system. The objective of this study is to find the parents' attitude on video game before and after the training of structured spatial skill training educational video game by their children. So it's an observational study. A random sampling of the sample size 19 is done. Inclusion criteria: the parents of the kids between the age group 6 to 10 years, those who are diagnosed as CP, and these CP kids have undergone 2 months therapeutic training on SST edu game to improve the spatial skill and mathematical skill. Parents who have children below 6 years and above 8 years, and those kids are also diagnosed as CP or excluded from the study. The self-administered questionnaire was given to the parents who satisfied this inclusion criteria. The questions are related to the game type, time restrictions, acceptance, addiction, fun, progressions, special features, duration of the play, years of the play by the child. The questions are framed in such a way that the parent have to answer either yes, no, or maybe. The cross-section analysis was done before and after the structured spatial skill educational video game by their children after getting the informed consent. The data were analyzed to check the frequency distribution of yes, no, or maybe. So the table shows the responses before and after the training session. The results clearly says that the parents agreed that this game is related to academic improvement, and this game has time restrictions. Most of the parents allow their children to play this game and reported that their child is not addicted. They are also happy while playing the game, and the progression of the video game is discussed with the parents. And they like the cartoon character Sai and Stee, and most of the parents agreed that this therapeutically designed video game. Parents are more concerned on the change in the child's behavior if a new game is introduced. So the selection of the game is strongly influenced by the experts and teachers. And the factors which influences games are usefulness, ease of game, learning opportunities, norms, negative aspects, and personal experience. The parents and teachers have similar attitude. Why? The parents are highly influenced by the teachers. So the parents play a media gatekeeper, so who plays an important role in selection. So it significantly affects the child's attitude and engagement in the game. The perception of the game is not uniform between the parents, which typically affects the acceptance of the novel video game in rehabilitation and educational systems. Parents exhibit both positive and negative attitude towards the acceptance of the digital game. By this study, it proves that this game is therapeutically designed and is accepted by most of the parents. So this is again proved by another study by the author, which he reported the parents are aware of the use of appropriate technology and the screen time, specifically in the current COVID situation. So to conclude, the game-based learning have high degree of flexibility and responsiveness, and it is a major role in determining the adaptability of the novel games. Physiotherapists are the connector between the healthcare and educators, working together with the family, healthcare professions, and educators. So digital games will improve the spatial skills, problem solving, memory, and attention of the child. Future implication, this game prototype is already submitted to the UGC's University Monitoring Portal. The game can be implemented as a pedagogy of teaching and learning for the typically and atypically developing children. Parents should recognize the good effects of the educational system and should limit the time and content of the game. So this is a bibliography, and thank you for the wonderful response.
Thank you, Dr. Madhumita ma'am. Now it's time for question answer session. So I would like to invite Dr. Manoj sir to ask questions.
Yeah, good morning, everyone. Good morning, Dr. Madhumita. It was a good presentation. It was a good presentation. Can you just tell me what were your objectives of the study? What were your primary objectives?
The primary objective of this study to know what is the attitude of the parents, because when I'm approaching the special schools, while I'm mailing to the directors, one of the quoted a subject like, I need permission to do the data collection. So she replied with a note that we don't give the permission, parents have to give the permission. So this paved me to do this study. So we have to get the permission from the parents. So in order to do that, we have to understand what is the attitude of the parents. So before going to the training, so we collected the response, and after training, we collected the response to get what is the attitude before and after, whether they are accepting the game, whether they are allowing the child to play the game. This is the objective of the study, sir.
It is just to see the parents' acceptance towards playing game, correct?
Yes, sir. Yes, sir.
Okay. Can you just say in inclusion criteria, you said, can you just go to the inclusion criteria and share that? You need not share it, you can just say what your inclusion criteria
Yes,
were.
inclusion criteria, children with the age group 6 to 10, those are diagnosed with the CP, any varieties, with the MAC level 1 and 2, and those who can able to communicate easily and understand the instructions are included in the study. Those who have parents are included in the study. Those who have kids within the below the age group 6 and above the age group 10, and those who are diagnosed with the CP with all varieties and the MAC level 1 and 2 are excluded, because below 6 and above 8 we are not designed the game for those populations. So the parents of those kids are excluded.
Okay. There was another criteria, no, that there was some.
Yes, sir. The other criteria is those who underwent a 2 months structural spatial skill training program, because the child have to undergo 2 months training. So after that only we can able to get the response from the parents.
Okay, I understand. The students are undergoing 2 months of response training. That is okay. Won't you think that will have a crossover effect?
Yes, sir, but obviously we have to find before and after, because I cannot go along with a 1 week or 2 weeks. I have to wait till the end because we have to make sure the child is not going for addiction to the game. So total duration of the study have to go, then only we can get the response.
Okay. So then another outcome which you said, parents' acceptance and the addiction towards the game. So how did you rule out that the students were not addicted towards the game?
Yes, before sampling technique, randomized sampling technique, the parents were highly give a what to say, counseling session. Not counseling, it's an intro section. Like if the children is having addiction to the game, they are excluded from starting itself. Before collecting the response, starting itself, we are excluded them from the study. So high scrutinization done before. So those who are not addicted to the game, they are alone included for the study. So those parents only included, but still we have to find the child is not going for addiction, because addiction is not what to say, it is not needed. It should be avoided. So
yes,
high scrutinization done before itself.
Yeah, I understand. I'm just asking whether you used any outcome measure to quantify the addiction level.
No, sir, no questionnaire is used. Only the question, what to say, only the we will go for before starting the training session, we will get the demographic details, one questionnaire format. In that, a single statement is given whether your child is addicted to any game. So a single question is given. From that only we are taking out.
Yeah, I understand that. My question is just asking you, don't you think it would be better, no, if you could have a
Yes, sir, it will be better. If we're going for a very larger population, the addiction scale in a detailed format, if we get, it will be giving a more wonderful effects. So this it's a preliminary stage, and these findings is only for the pilot study findings. But if it is going for the next level for a bigger population, highly suggested is to get the addiction questionnaire value.
Okay, what did you conclude? What was your findings of your study?
This study or major study, sir?
No, yeah, the study which you presented.
This study, parents accepted the game. So from the educational point of view, because it is having maze, puzzles, matching shapes, birds, animals. So the child can able to correlate this game along with their academics. So they accepted it, and there is time restriction, because after 40 minutes, the game session will be locked by itself. After that, we cannot play the game. So they are happy with that game instructions, game time restrictions, and hints and instructions they can able to understand, and that's all given in the Tamil format also, so they can able to clarify if they have any doubts. And children are very happy by seeing the cartoon characters Tree and Stry, because C and Stry will be speaking to them if they click the hints and instruction back. And scoring system they are enjoying. And most of the parents are worried that when the child played the game, they are not giving any response what they are doing. But here what happened is they are discussing with the parents, I finished this, I finished the level 1 or level 2. Say they are discussing with the parents. So the parents told they are happy. And one parent said that his child is addicted to some game. So she, after finishing the game, she felt very happy, and she asked also what is the next level. So it will be, I said like it will take around 1 or 2 years to tell what's really going to happen, because it's only a pilot study.
Okay. That's fine. So what was the primary outcome measure which you used
for
the study?
For this, no outcomes, sir. For the main study, we are having 5 outcome measures. So Corsi block test and Corsi block test, Vandenberg and Hughes mental rotation task, and motor coordination. Then spatial skill, spatial perception of Berry VMI. Then max is evaluated by 1 minute max test by Westwood.
Okay. What was that last slide? You spoke something.
Yes, last slide. What we lost here, we got an what to say from a letter from the university. that according to NEP 2020, they are asking for a newly developed toys or a play integrated learning to submit to the government. So in Man Ki Baat, in the date 30 August 2020, Prime Minister added that if you have any newly invented toys or play integrated learning, please upload to the UGC University's activity monitoring portal. So I went forward along with my guidance. So submitted to the our VC, college VC. Then he is transferred to the advisor. So advisor asked me to what is the content of the game. I explained. So after explanation, it's transformed into the all the games. This content is transformed into the PDF and submitted to the UGC portal, sir.
Okay, it's a good initiative. Who's your guide, by the way?
Dr. Sendil Selvam, sir.
Fine. Okay then. Thank you, Madhumita.
Thank you, sir.
Thank you, Dr. Manoj, sir, and thank you, Dr. Madhumita, ma'am. Next, move on to next candidate, Dr. Priya Kumari from Wales Institute of Science, Technology and Advanced Science from Chennai.
To one and all present here. First of all, I would like to thank PPG PHYSIOCON for giving me this wonderful opportunity. My topic for today is the effect of therapeutic exercises on verbal memory in obese women with polycystic ovary syndrome. And these are the topics which I will be covering today. Before I get into my topic, I would like to throw some light on issues related with PCOS. When PCOS is spoken about, mostly the issues like fertility, physiological changes, psychological changes, and then metabolic issues, physical changes are mostly focused on. But there are certain other issues which are under research currently and which are more of concern. One amongst such is cognition, which is more disabling. Now, PCOS, as we all know, is a hormonal imbalance problem. It was first introduced by Steen and Leventhal. And according to WHO, nearly 116 million women across the globe are affected with PCOS. In India, the prevalence is nearly 9.13% to 36%. Now, when we talk about the signs and symptoms, PCOS affects the mental, physical, psychological, and physiological aspects of the women. Now, we talk about the cognitive issues. There are all the cognitive domains which are affected. Most of the cognitive domains are affected. One such among is the verbal memory. Verbal memory is nothing but it's the ability to remember what we hear or read a few days or a week before. It involves the ability to recall words, verbal items, or language-based memory. The hippocampus mediates verbal memory. And when we talk about the effect of exercise, well, exercise increases the blood supply to the brain. It strengthens the network connections. Gray matter thickness improves, network tuning improves, and neurotransmitter efficacy increases with the help of the therapeutic exercises. Now, background, the PCOS is a social stigma that affects the women's identity to the core. It affects the mental health and quality of life of women. So, ovaries should not be considered only a production tool. Other aspects also associated with the ovary. And in case of the PCOS women, there is a increased free androgens, because of which a hormonal imbalance is created, and that affects the cognitive domains. And now, there are researches which has shown that brain activity in case of the PCOS women improves when they are asked to perform certain memory tasks, as compared to the women, those who are not having PCOS. And also the PCOS, according to Rees et al., cognitive performance was poorer in case of the PCOS women. These are my aims and objective. Aim is to investigate the effectiveness of therapeutic exercise on verbal memory in obese PCOS women. Methodology, it's experimental study. A convenient sampling was done for 12 weeks. These are my inclusion criteria. Exclusion criteria. An outcome measure is verbal memory, was measured using the auditory verbal learning test. This is a flow chart which shows the 48 PCOS women based on inclusion and exclusion criteria were selected. There were 8 dropouts, and remaining were divided into randomly into 2 groups, experimental and control. A group was given the intervention, that is therapeutic exercises. B was given the lifestyle modification. And pre-test and post-test evaluation was done using Ray auditory verbal learning test. Now, data intervention, if we see, in group A was given 3 therapeutic exercises, which included brain gym, Surya Namaskar, aerobic exercise, and strengthening activities for 12 weeks. Group B was given lifestyle modification, which included counseling, diet modification, and mild exercises. The data analysis shows the analysis of the subtype of verbal memory, that is your immediate recall. This is a table and graph for delayed recall, and this is table and graph for recognition memory. Our result shows that immediate recall, delayed recall, recognition memory, on all the aspects, the experimental group, there was a significant difference as compared to the control group. And though the improvement was in both the groups, but experimental group performed better. On discussion, the current study, post-intervention, obese PCOS women performed better on RABLT test. According to the result, both the groups improved, but there was better performance in group A. And according to Boivin et al., women with PCOS are subject to poorer neuropsychological performance. So there is a need of the awareness of cognitive issues in the PCOS women. They should consider it for the wholesome health development. And one such domain of cognition which is affected is verbal memory, which is of utmost importance for leading a better quality of life. Because in PCOS, hormonal imbalance is there, it will affect the cognitive functions, synaptogenesis, neural networking, and chemical release inside the brain because of the hormonal imbalance. As such, and as a result, the cognition gets affected. So therapeutic exercise plays a role and improves the performance of the cognition in case of the PCOS women. Our conclusion is that therapeutic exercises has a significant effect on cognitive domains in PCOS. So take-home message would be for wholesome health and for doing multitasking as women do efficiently, sound cognition is required, sound verbal memory is required, which can be achieved with the help of the exercises. These are my references. Thank you.
Thank you, Dr. Priya Kumari ma'am. Now it's time for question session. So I would like to invite Dr. Manoj sir to ask questions.
It was a nice, interesting thing, Dr. Priya. Just a few questions. What do you mean by the, or what is the operational definition for these therapeutic exercises which you are suggesting?
It is a structured exercise because it's not just a single exercise which I'm going to give. It's a combination of exercises after going through a lot of research and the effect of different set of exercises on PCOS women, because there are already so many studies related to the effect of aerobic exercise separately or strengthening exercise. But there is like a combination along with like brain gym, which is like, because I'm talking more about cognition. So that's why it is included all the combination exercise.
Yeah, I get it. So in other words, that is this therapeutic exercises which you are suggesting is been formed by you. Am I right?
Yes, sir. It's
okay.
Actually this type, yeah.
The another question is, if it has been formed by you, have you tested this to see the efficacy of the treatment?
Yes, so already I have done the pilot study and I have seen the effect on the limited sample size, the effect of therapeutic exercise. So I've already done the pilot study on this.
Okay, because we have to, since we are suggesting a new exercise regime, we should see the effectiveness, so whether it is valid and reliable before start using. So that is what I wanted to make sure. And what exercises did the control group receive?
So control group, I have just given the lifestyle modification, which includes a mild aerobic exercise that is of, and diet counseling, and just a bit of counseling. That's it, sir.
Okay. So the experiment also would be given the same diet counseling and
Yes, sir. Diet will be there, sir.
diet will be there. So that is common for both. The diet is common for both.
Yes.
You're just asking them to do only aerobic exercise as the control
Yes.
group.
Yes, sir.
So in the conclusion, when you suggested, you said that both group were beneficial.
Yes, sir.
Any specific reasons or?
Yes, sir, because we know already there are studies also, and the exercise has a very good effect on the improvement of cognition and other parameters. So already they are also doing aerobic exercise, so there is improvement. But when we compare with the therapeutic exercise, which is having a combination of brain gym, aerobic, and Surya Namaskar, so that effect is more as compared to giving only aerobic and other lifestyle modification.
Okay, so you say that the new exercise regime which you have devised was much better than what is really existing. Okay,
Yes.
so in that, just out of curiosity, which aspect do you think would have caused that extra effect? Because both sides have the same aerobic exercise. So you think
Yeah,
the
but-
brain?
Yes, sir, but here I'm giving a resistance exercise also. Along with that, I'm giving brain gym exercises, which helps in the visual imagination, and it activates, especially the brain gym activates both the sides of the brain simultaneously. So that component is missing in this control group. So I think this combination has added more.
Okay. So can we conclude that brain gym is better?
Yes, sir, it is better. It is effective.
Okay. Okay then. Thank you.
Along with other, because PCOS is not only it has other problems also. So it's a metabolic disorder. So it's and I've taken obese women. So if I give only brain gym, maybe the some purpose won't be solved. But because I'm giving it other exercises, so it is more effective.
Yeah, I understand, but the objective was only for recall, correct?
Oh, yes.
So when you just talk only for recall, I think brain gym should have been best. For PCOS, I understand. Correct.
Yes.
Isn't it? Isn't it, Priya? Huh?
Yes.
Okay. Okay then.
Sir, but if if I'm taking obese women, if that problem is not solved, so the effect won't be much there, because as such obesity is another problem, and there will be a lot of imbalance, other issues which will directly affect the brain also cognition. So the impact which will happen by doing only brain gym exercise won't be much visible. When I give the combination exercise, it's taking care of the other parameters also. Along with that, the cognition is also, it's affecting on cognition as well.
Okay. Okay then. Thank you.
Thank you, sir.
Thank you, sir, and thank you, ma'am. So next we move on to next candidate, Dr. Sri C. Rajeshwari from Wales Institute of Science, Technology and Advanced Sciences from Chennai.
Good morning to all. I'm going to present about a comparative study of brain gym and dynamic movement skill on working memory in middle-aged women with memory oblivion. Background of the study: working memory is a domain of human cognition that underlies the temporary storage and manipulation of information. Whitwell et al. In 2018 done a study: working memory in older adults declines with age. So working memory in healthy aging has important translation impact. They found that aging detrimentally affects various aspects of working memory performance. So in the current study, I chose two different interventions to evaluate the working memory performance in middle-aged women. Objective: this study is to compare brain gym and dynamic movement skill on working memory in middle-aged women with memory oblivion. Methodology: study setting, School of Physiotherapy, Vistas. Study design: experimental study design, sampling, random sampling, sample size 100, exercise session 5 days per week for 2 weeks, for 12 weeks. Inclusion criteria: age 40 to 50 years, BMI 18.5 to 24.9 kilogram per meter square, gender female. In memory complaints here, they had a score between 7 to 10. VO2 max is calculated by using personalized chapters, and range is 31 to 41 ml per kilogram into minute. Exclusion criteria: history of diabetes mellitus, hypertension, psychiatric or systemic disease, and restricted mobility, orthopedic, neurological, and cardiovascular disease, history of surgery in last 6 months, bone density problem. In PAR questionnaire, if they answer yes to one of the question, they are excluded. Outcome measure digits memory test, digit span forward and backward tasks are taken to evaluate the working memory performance. The procedure is the examiner pronounces a list of digits at a rate of approximately 1 digit per second. It starts with 3 items and it ends with maximum of 9 items. Brain gym. Group A brain gym, the sample is 50. Brain gym is a program of exercise that focusing on performing on specific physical activities that activating the brain. I will show some brain gym videos. For sample, I'm giving this video. Brain button, marching, figure of 8, figure of 8 in both the hands, clap behind the knee, and cross crawl. So exercise duration is 25 minutes, warm up 5 minutes, and cool down 5 minutes. Dynamic movement skill. It is a training and rehabilitation methodology that stimulates the central and peripheral nervous system. It helps to refine and develop neuromuscular efficiency and to change motor pattern to make the movement more efficient. I used this mat to perform the exercise. It had a B, C, D, and 1, 2, 3, 4. Based on the number and alphabet, the exercise will be there. I will show the sample video. Quick fit to B with the left leader. Quick fit backward to C, left leader. Quick fit to D with two-handed catch. It is a dual exercises. The brain will think about the movement and according to that, the person will do the exercises. Quick fit to A with two-handed juggle, left leader. So total exercise duration is 25 minutes and cool down 5 minutes. Data analysis and interpretation. In group A, digit forward and digit backward task scores are improved significantly, P less than 0.01. And in group B, it's not significant. The values are almost the same. Comparing percentage increase, it shows that both group A and group B improved significantly, but group B had a higher performance in digit forward and digit backward task scores. Result between group percentage of increase comparison of outcome. Percentage increase in digit forward and digit backward post test score is higher in group B than group A, but post test scores of both the group improved significantly, P less than 0.01. Discussion based on statistical analysis, it shows that both the group improved significantly. So the finding of the study are similar to some previous studies. Casper de Boer et al. In 2018, they concluded that the intervention induced neuronal changes on the level of network that are not only relevant to the task at hand, but also for more general abilities of brain. In brain gym and dynamic movement skill, the movements which I gave, the brain will think about the movement and the person will perform the exercise. So in exercise like resisted exercise, high intensity interval training, and aerobic exercise, the person physically will do the exercise. So in these type of exercise like brain gym and dynamic movement skill, both physically and mentally, the subject will perform the exercise. So Lianka et al. In 2015, brain plasticity is a lifetime developmental process and continues to play a similar role in older adulthood. So neural plasticity is the ability of the brain to change, to repair, and to reorganize itself. When using this type of dynamic movement skill exercises, so experience-dependent changes in the lower neocortical region can reshape the activation pattern and the anatomy of cerebral cortex. Sensory input motor learning activities can stimulate the cortical changes. These type of skill learning stimulation experience relevant neuron often fire together and wire together. Conclusion: this study concluded that both brain gym and dynamic movement skill intervention showed a significant improvement of working memory performance in middle-aged women. The limitations of this study are: I didn't take an account whether the women are in pre-menopause, menopause, or in post-menopause stage. So in future studies, it has to be added up. These are all the reference.
Thank you, Dr. Rajeshri ma'am. Now I invite Dr. Manoj sir to ask questions.
It is an interesting study, Dr. Rajeshri.
Thank you, sir. Good morning, sir.
Morning. just wanted to ask you, why did you want to select only middle-aged group?
Because if we take Alzheimer's disease and dementia, that neuropathological process will take place in the brain 10 to 20 years prior to the diagnosis of dementia, sir. It is from Cochrane review and some meta-analysis study, I found the word. So if we give proper intervention at the middle age, we can prevent or postpone the Alzheimer's disease and dementia in the later stage, and we can improve their functional independence, sir. So that's why I chose the middle-aged women, and women are more prone to dementia and Alzheimer's disease when compared with men, because if we take that PET positron emission tomography scan, the woman both when compared with the woman and men with same age, the woman had a more protein taut tangles found in the brain, and it destroys the nerve cells in the brain when compared with men. If the men had a 10% mean, woman had a 30%. So there are so many risk factors for this. The one is because women had a more longevity when compared with men. And second thing is they may have that hormonal imbalance during that menopause stage. So these are all some of the risk factors for women. They are more prone for the disease like Alzheimer's disease and dementia. That's why I chose the middle-aged women, sir.
Okay. So the next question was concerning the menopause and the dementia. That is what I wanted to ask you. So
yes,
you're
sir.
saying that if you start giving early exercises, it can prevent
yes,
dementia post menopause.
Yes, sir.
Yes.
Prevention is better than cure. That's why I chose beforely, sir.
Okay. So one received one was that exercise which they did, the brain gym. The other was what the other was
dynamic movement skills, sir.
Yes, sir. Okay, just to ask, one was more of an agility training, correct? The board which they were doing.
In the mat, sir, in the dynamic movement skill mat. Yes, sir.
So it was more of an agility or more of a, it's more quicker when compared to the other thing, isn't it? So how do you think?
Yes.
Did
Yes,
it
sir.
play any difference?
Yes, sir. What I felt was, sir, the dynamic, both the intervention, it is improving actually, sir. Both intervention, it's good, it's improving. What I felt is in discussion, dynamic movement skill had a more complexity of novel movement when compared with brain gym, sir. That's why it had a higher percentage increase in working memory when compared with brain gym, sir.
Okay.
I done this course in London, sir. That's why I chose that mat and exercise to perform to evaluate the working memory performance. It's all cognitive movements, sir. Both brain gym and dynamic movements, sir, both the things I use the cognitive movements to.
Okay. Just out of curiosity, just ask why you didn't have a control group.
So it's an experimental study. So I want to give equal weightage to both the interventions. So definitely control group, I will not focus on much. So I'm giving two equal intervention, giving equal weightage. That's why then only I know which is good and which is improving faster when compared with other.
Yeah, that is a nice idea. But the reason to have a control group, you can get some baseline. You can get some baseline value. When the patient is, so that you will know the actual improvement from the baseline value rather than knowing which is better when both are improving.
Okay, sir. Okay, sir. Okay, sir.
So it's good. Okay then.
Okay, sir.
Then
thank you, sir.
Thank you.
Thank you, sir.
Thank you, Manoj sir, and thank you, Rajeshri ma'am.
Thank
you. Thank you, ma'am. Next, we move on to candidate Dr. P. Suganya, ma'am, from Wales Institute of Science Technology from Chennai.
Good morning, everyone. I am Suganya. My title is a study on comparison of short-term CrossFit and high-intensity interval training on mood states in collegiate athletes. Content of my study, and the background of my study. Modern-day college students undergo immense pressure to achieve the academic performance due to heavy competition. In addition to this, adjusting to life away from home, social demands, and financial changes are the few other burdens that the students have to confront in modern days. Along with this, normal stress also increases a collegiate athlete's risk of experiencing physical as well as mental issues. Physical exercise and mood improvement relationship have been studied in multiple studies. And physical exercise is effective tool for self-regulation of well-being in normal population. It reduces negative mood, increases energy, and reduces tension. Among the strength and conditioning training method, CrossFit and HIIT are the popular one these days. Mood state assessment provides a reliable and easy way to measure the responses to training load. And one of the effective measures through the use of profile of mood states. Its advantage is detecting mood fluctuation associated with the exercise. Objective of my study is to find out the effectiveness of CrossFit and mood states, and to find out the effectiveness of HIIT and mood states, and to compare the effectiveness of CrossFit and HIIT on mood states in collegiate athletes. Methodology: study design, experimental study, convenient sampling, sample size is 54, study setting is in VISTA, study duration is 6 weeks. Inclusion criteria: only males were included, age were between 18 to 25, BMI 20 to 25, and those who have low risk category in physical activity readiness questionnaire, and those with medically fit with normal ECG report. Those who have passed stone transverse abdominis activation is positive. Exclusion criteria: musculoskeletal injuries and with cardiorespiratory conditions, bodybuilders, systemic illness are excluded. Mood state is the outcome measure, and it is measured by a profile of mood state questionnaire. Procedure: 68 male collegiate were recruited. Among those, 54 male college athletes were selected. Dropout were 14. They were enrolled after they signed the institutionally approved consent form, and all the COVID-19 precautions were explained to the participant before. Then they were randomly allocated into Group A and Group B. Pre-tests were taken 20 minutes prior to the start of the session, and after 4 weeks of CrossFit and HIIT training, post-tests were taken 20 minutes after the end of the session. Data analysis were done to compare the pre and the post. CrossFit training, it's constantly varied a high intensity exercise. So the total duration is 40 minutes, including warm up and cool down. It contains a variety of exercise, including gymnastics, weightlifting, and metabolic conditioning. So this is done based on the CrossFit guidelines. The HIIT protocol, here also 40 minutes duration in thrice a week for 4 weeks, including warm up and cool down. Work to recover ratio 1:1. So training intensity 80 to 90%, recovery intensity 40 to 50%. Training regimen: running, rowing, dumbbell lift, cycle ergometer, kettlebell swing. Result shows that Group A pre with the post shows statistically significant, and Group B with the Group B pre with the post shows statistically significant, and the p-value is 0.44. The individual mood states were also analyzed. Anger, confusion, depression, and tension were reduced in both Group A and Group B, and fatigue and vigor were increased in both Group A and Group B. This shows in fatigue, so fatigue shows increased in Group B than Group A, and vigor were increased in Group A than Group B. So percentage increase in all the mood states were higher in Group A than the Group B. So according to Pavlov et al., 8 weeks of CrossFit program was useful in increasing the self-confidence and improving mood. This study is supporting my study, and Nicholas stated that women are more enjoying in doing the CrossFit training when compared to the resistance or moderate intensity. This also correlates with my study. And participants in Group B experience more fatigue. This might be due to repetition of same type of high intensity exercises, and like the CrossFit, which contains a variety of exercises. Alexander et al. Stated that HIIT body workout led to changes in mood level and progressive reduction in affectivity. Any negative changes in psychological status and early symptom of overtraining syndrome in that side. Maybe a long-term CrossFit or HIIT may provide enough volume to produce positive effects, even in individuals with a high relative level of fitness, and they will get a greater time to train each component of fitness. So it's concluded that CrossFit training is found to be effective in reducing active mood than HIIT in male collegiate athletes. So incorporating regular CrossFit and HIIT protocols in their training regimen will help to minimize their mood disturbances created during competition, which in turn enhances athletes' performance. The limitation duration is less, only male is studied. Administration of this questionnaire in different time might be giving a different result. Thank you.
Thank you, Dr. P. Suganya, ma'am. Now it's time for question and answer session. So I would like to invite Dr. Manoj sir to ask questions.
Yeah, Suganya.
Good morning, sir.
Morning,
Good
morning.
morning,
It is a different study. The first thing when you told about the topic, I thought you are talking on moods. I thought it would be females. Why males?
Because I'm giving high intensity training, so I selected male collegiate athletes.
Yeah, that is okay. But normally, who normally has mood swings or mood problems?
Both sex have equally have mood problems. That is negative problem. So only I selected male.
Okay. No, I just wanted to, because I thought women had more mood swings and more of that. So that is why I was thinking. That's okay. Coming on to the exercises, you did one is CrossFit, isn't it? So is it based on the protocol?
Yes, sir. It is done under the guidelines of CrossFit, which is given in the CrossFit website, and with the help of CrossFit trainer, we have made this protocol. And also, I did a pilot study, so it supports me.
Yeah, fine. And HIIT is just a protocol, right?
Yes, sir. We can form variety of protocol by altering the intensity and the work to rest ratio. So according to that, I have made this protocol.
Okay, I don't know. Just asking. Even CrossFit also will be under the HIIT protocol, isn't it, or will it differ?
Yes, there is an article suggesting that so far no studies are done to compare CrossFit with high intensity exercise. No studies have proven that both are same. CrossFit and HIIT are same. So to know the differences, I am doing this study.
Okay, that is one point you're looking. Okay, when you look at the other way, both has component of aerobic and resisted training, isn't it?
No, sir. Both are anaerobic, sir, because it is high intensity exercise.
Okay. Okay, if you are doing, if I don't know, if you're doing anaerobic exercises, you said the total time period is going to be for 40 minutes.
Yes, sir. As many repetition as possible is the main component in CrossFit, sir. And in HIIT, I regularly monitored the heart rate of the participants. So from that, so I gave the intensity as 80 to 90%, which is anaerobic training zone. So according to that, it was done.
So what is the time duration for each exercise, if at all you did?
Totally 30 minutes, sir, training, 5 minutes warm up, 5 minutes cool down.
Okay, so 30 minutes, I don't know, like anaerobic, will they be able to sustain for 30 minutes?
Sir, they in high intensity exercise, in 3 minutes they done the intensity exercise. After that, the recovery intensity is 3 minutes. Sir. In that recovery intensity, they took some rest. After that, they continued that again the high intensity exercise. In CrossFit also, they have time limit, as many repetition as possible. They done, sir.
Okay, so
Not fully high intensity, not continuously high intensity. In between, rest are given, sir. That is recovery intensity.
okay, and what did you conclude?
CrossFit is more effective in reducing negative mood than HIIT. So both are reducing negative mood. Totally exercise will reduce negative mood. So among those training methods, CrossFit is more effective.
Okay, because it's already known, that exercise helps you to increase your adrenaline and your mood gets elevated.
Yes, the training portal. I wanted to know which training protocol. It will be it will be incorporated in that regimen for practicing. So that's why.
So if you think that way, you are using 2 anaerobic exercises as you suggested to see which is better. Don't you think it would have been better if you compared one anaerobic and an aerobic to see which was better?
So definitely anaerobic is better in athletes because it will increase the strength and everything. Not only endurance. So aerobic will improve the endurance, but anaerobic will increase the strength and also endurance.
Yeah, I understand. But our study was just to find out whether the mood is improved or not, isn't it? We are not talking on the endurance or the. So when you look at that aspect, it wouldn't have been much more better if you would had something.
Because sir, I'm doing main study. My outcome measure was anaerobic capacity, upper body power, lower body power. So for supporting my main study, I wanted to know their mood state while doing this training. So I have done this study.
Okay then. Okay. Thank you.
Thank you.
Thank you, sir, and thank you, ma'am. Next, we move on to the other candidate, Dr. Kishore Kumar from Wales Institute of Science, Technology and Advanced Sciences from Chennai.
Good evening, one and all. I am Kishore Kumar, Research Scholar, School of Physiotherapy, Vistas. My scientific paper is on effectiveness of early passive mobilization versus early active mobilization protocols on total active motion and grip strength in flexor tendon zone 2 repair, a pilot study. Objectives were to determine the effectiveness of early passive mobilization and early active mobilization techniques in improving the total active motion and grip strength, to compare both techniques for determining the effective technique. Need and background. Lawrence Samuel Frew et al. In 2014 stated that there were few studies comparing both protocols. Hence, I intended comparing both techniques and determine better effective protocol in improving total active motion and grip strength. Inclusion criteria were age greater than 18 years, injury to one or both flexor tendons in zone 2, sharp lacerations, no associated injuries of joint, nerves, and vessels, primary flexor tendon repair in zone 2, no associated digital fractures. Exclusion criteria were critical ischemia of limb or digits, immobilization protocols, digital, joint, and vessel injuries, associated extensor tendon injury, associated phalangeal fractures, concomitant nerve injury, and crushing injury. Methodology where study design is experimental, study setting, School of Physiotherapy, Vistas, and Wright Hospital, Chennai. Study duration is 8 weeks, non-probability convenient sampling method, and sample size is 12 in number. Procedure: after getting approval from the ethics committee, 17 subjects were identified, out of which 12 met the inclusion criteria and were equally allotted in Group A and Group B. Follow-up were done at 4 weeks and 8 weeks period. The total active motion and grip strength were assessed at 4 weeks and 8 weeks. Let's see the protocols. First, the modified Duran protocol. You can see the exercises within the splint. So you can see the isolated DAP joint flexion with PAP joint held in flexion in the first picture video, and in this you can see the isolated proximal differential joint flexion with distal differential joint held in flexion. So these two separate exercises were used for isolated gliding of flexor digitorum profundus and flexor digitorum superficialis tendons, and in addition to that passive composite flexion of MCP, PIP, and DIP joints were done. Passive exercises done twice daily, 6 to 8 repetitions per exercise per session. Belfast protocol. So we'll directly go to the exercise. So you can see the active flexion of the repaired index finger within the splint. These exercises performed for 2 repetitions of full passive flexion, active flexion and extension. So these exercises were done for 4 weeks within the splint. After 4 weeks, the protocol is same for both groups. So after 4 weeks, gliding exercises, straight fist, full hook fist and full fist or normal fist exercises, which glides FDP and FDS tendons. Blocking exercises by bundle, isolated FDP gliding and isolated FDS gliding. Progressive resisted exercises after 6 weeks in form of resistances by medicinal ball, therapeutic, manual resistance, Velcro board and finger exerciser. Splints are given in case of flexion contraction in the proximal interphalangeal joints. After 6 weeks, you can see the PIP joint deformity. This is the finger straightening splint. Apart from these, activities of daily living were trained using the template which is present in our department. Functional activities, which is the ultimate goal of any hand rehabilitation, gained by sustained grasp activities and Velcro board activities for improving the strength of both long flexor tendons and extensor tendons. Outcome measures were total active motion measured by goniometer and total active motion score. Grip strength measured by Jammer dynamometer. You can see the grip strength measured in this female patient. The data statistically analyzed by independent t-test and pair t-test. Results: statistical difference in mean TM values, p-value less than 0.05 between 2 groups. No significant difference in mean grip strength values statistically, but clinically significant. Hence, the current study showed that Group B is better in outcomes than Group A. You can see the graph which shows mean TAM and mean grip strength value, which is greater in Group B. Discussion: significant difference in TAM in both groups, which is consistent with previous studies. AM prevents extrinsic healing, facilitates intrinsic healing, and you can see the results that there are better outcomes in Group B than Group A. Total percent of good and excellent rates, 60%, which is lower than most of the reports, and 8 weeks is not the end point of functional recovery. Joy McDermott stated that grip strength was the most studied and reliability of grip strength well established, and there is no significant difference in mean grip strength in 2 groups, but clinically significant. Conclusion: target subjects recruited successfully. Furthermore, subjects compiled with the study protocols. Outcomes of TAM and grip strength better in Group B, that is EAM protocol, than Group A. EAM more effective than EPM protocol. Pilot study shows feasibility and promise to proceed further main study with larger samples. So these are my references.
Thank you, Dr. Kishore Kumar sir. Now I would like to invite Dr. Manoj sir for asking the questions.
Dr. Kishore.
Good evening, sir.
Good
evening. Good afternoon, sir. Good
afternoon. Yeah, it's a nice, interesting. I have a lot of questions. I don't know.
Yes, sir.
Your
Yes,
topic
sir.
is.
Please, I'm happy to answer, sir.
Yeah. First and foremost, why zone 2?
Sir, zone 2, there are 5 zones in flexor tendons. Based on the ease of surgery and therapy, it is classified. Zone 2 is known as no man's zone because in zone 2 there are only 2 tendons present. It is a small area. It is present between the distal palmar crease. I think you can see this distal palmar crease and between the insertion of this thing FDS in the ear in the middle phalanx. This area there is only 2 tendons, FDP and FDS tendons. It is a tiny area. And it is very critical for rehabilitation because more of adhesions will be formed within these tendons after the surgery. Because even the surgery is a surgical trauma, it causes more adhesions in that area, and eventually surgeons will be very cautious to touch in that area. To do surgery in this area to do more adhesion formations, and the functional outcome is very poor when compared to other zones.
So you are concentrating that based on the functional outcome, zone 2 has got a poor outcome.
Yes, sir.
So
Yes, sir. Yes, sir. As it is challenging, I took that zone for rehabilitation. So functional outcome is poor in, usually it is poor in joint. The joint stiffness is more common in PIP joint of the fingers, and muscle strength is also reduced. So I took as a challenge to take this zone as my study.
Another common question is why you wanted to compare something which is active with passive?
Actually, these are standardized protocols, sir. Belfast protocol is known as a early active motion protocol, and modified Duran protocol. What I done is it is a early passive mobilization protocol. So actually, both has its own advantages. Actually, in olden days, that is before 15-20 years, only immobilization protocols are followed. That is immediately after surgery of zone 2, usually go for 3 to 4 weeks of immobilization of the hand. So what happens is the immobilization is done in the extension position, and what happens, there is stiffness of metacarpophalangeal joints, PIP and DIP joints. That in the 3 weeks, the additions are very profound, and you can't rehabilitate. It results in eventually in deformities of the fingers. So it can't be recovered. But in recent times, that is since 2010, this early passive mobilization techniques and early active mobilization techniques are commencing, sir, because this is mainly due to reduce the immobilization time. Reduce the immobilization time. That is, the 3 weeks immobilization is avoided, and the tendon is that is, the joint is mobilized very in a gentle manner from the day 1 or day 2 of the surgery, after the surgery, post-operative day. What is the difference is, in early passive mobilization, only the joint mobilized passively, and in early active mobilization, both passive as well as active contraction of the repaired tendon takes place. So there are its own advantages and disadvantages. Disadvantages: rupture rates are high in early active mobilization. So that's why we are starting very cautiously, only with 2 repetitions of active contraction of the finger. Only 2 repetitions. Yes, sir.
Yeah. Since you said active is better, then why compare it with passive?
Yes, sir. As I told, sir, because rupture rates are equally high, sir, in active, sir. Because immediately after doing surgery, if we are giving active contraction after 1 or 2 days, there is equal risk of rupture rates. But still, if we give cautiously in a systematic manner, there is good outcome compared to early passive mobilization. So it's an experimental study, sir, because in recent times, these protocols are followed in UK and US countries, but it is not active in India. Only early passive mobilization is followed mostly. So I want to implement in our country for better outcomes, sir.
Yeah, and then the outcome measures were 2. One was range of motion, other was for grip strength.
Grip strength, yes, sir.
Yes. So range of motion, agreed. Both active and passive, if you do, it is correct. But coming out of the grip strength, that will improve only when you give active exercises, isn't it? So one group you are doing passive, and how can you measure grip strength doing it passively?
Sir,
don't you think the outcome measure is corresponding to your treatment?
Yes, sir. Actually, passive mobilization, that is for the first 4 weeks, sir. In both groups, that in early passive mobilization group, the passive range of motion of finger is only for first weeks within the splint, sir. So that actually in immobilization protocols, usually it will be immobilized for 4 weeks totally. But in early passive mobilization, we will start from the day 1, and passive mobilization is started for all joints. But still, grip strength is a component of all fingers. It is the grip strength combines all the other fingers, sir. Not only the injured finger.
No. I understand the passive mobilization. You start off early passive mobilization.
Yes, sir.
That is fine. I understand that.
Yes, sir.
But my understanding is passive mobilization doesn't improve your grip strength.
Yes, sir. That want to document in my studies, sir, because early I want to make sure early. Yes, sir.
So when you did the study, when you compared both passive and active, I was just thinking.
Yes, sir.
The range of motion is fine. I agree. for both it can be taken, because when you do active mobilization like active exercise also, there are chances for it to improve. Additions could break down, you could improve your range of motion. That is agreed.
Yes, sir.
But based on the grip strength, when you do actively, I think the grip strength would improve then rather than passively.
Yes,
so
sir.
that component you could have thought of something else, okay, rather than the grip strength. That is what I'm trying to say.
Yes, sir. The follow-up is done at 4 weeks and 8 weeks, sir. After 4 weeks in early passive mobilization group, active exercise has started.
Okay.
Only for the first 4 weeks, for based on the standardized protocols, I went through these this protocol for 4 weeks. First 4 weeks within the sprint, sir. After the 4 weeks, the protocol is same for both groups, sir. A group and B group. And I found good improvement only in B group in 4 weeks and 8 weeks, sir.
Yeah, that is active mobilization, isn't it?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay.
Yes, sir.
It's a good thing. Actually, we know that active mobilization would help us to improve much more faster than a passive thing.
Okay.
Okay. So good. It is a different, because not many study on the hand and the other things. No, mostly people are doing on other topics. So it is a different topic. So
yes, sir.
So good. So you can go ahead. Thank you.
Thank you, sir. Thank you, sir. Thank you so much, sir.
Thank you. Thank you, Manoj sir. And thank you, Kishore Kumar sir. Thank you very much.
Thank you.
Yeah. Next, I will call upon Nagarjuna, Dr. Nagarjuna sir from GEMS College of Physiotherapy, Andhra Pradesh.
Good morning, one and all. I'm Nagarjuna Narayan Sethi. Today I am going to present a review study on Parkinson tumor and physiotherapy management. Parkinson disease is a slow, long-term, progressive neurodegenerative disease that commonly occurs between 40 to 60 years. The features present with motor like rigidity, dyskinesia, tremor, and postural disturbances and non-motor symptoms. Patients with Parkinson disease suffer from limitation in activities of daily living and decreased quality of life due to decreased coordination, difficulties with precise movement. Tremor in Parkinson disease is characterized by 4 to 6 hertz frequency at rest in limbs with a distal predominance. Tremor is a common abnormal involuntary movement and affects daily living activities in persons with Parkinson disease. Tremor in Parkinson disease is typical with few features. It's neither consistent nor homogeneous across the patients and within the same patient. At different stages may diminish in later stages of Parkinson disease. Predominantly resting tremor and increase in amplitude and frequency by physical and psychological stress, and it's not present during sleep. The most effective medications are probably propranolol, primidine. Second-line therapy includes beta blockers, alpha-germin, gabapentin, and topiramate. In more severe therapy-resistant cases, deep brain stimulation of thalamus can be considered, but not all patients with Parkinson disease are responsive to pharmacotherapy or surgical therapy, which increases the importance of having multiple management options. Recent studies reported on positive outcomes of intensive physiotherapy on Parkinson disease. Evidence on effectiveness of method and protocol of physiotherapy techniques which can control resting tremors in Parkinson patient is inconclusive. The current study's objective is to identify the primary research that identified and proved the effectiveness of various physiotherapy techniques in managing tremors in patients with Parkinson disease. We have included RCTs, non-randomized parallel studies, pilot studies, case studies, and other systematic reviews. Studies were excluded if the primary outcome is to design protocol and use of advanced therapeutic intervention. Pharmacological and surgical management were excluded from the studies. A comprehensive literature search performed on PubMed, Medline, Science Direct, and Clinical Key database using keywords Parkinson disease, tremor, physiotherapy, rehabilitation using Boolean apparatus and OR. A total of 320 studies were identified by using keywords, and in that 23 studies were screened as per inclusion criteria, and others were excluded on the basis of title and abstract. From 23, 17 moderate to good quality articles were reviewed, and other 6 were excluded due to duplication, due to inappropriate methodology, and poor quality. So this is the review of few articles which I have reviewed for this study. In that, there are few RCTs, pre and post, and pilot studies were there, case reports were there, and those which are included in your study. So in summary, we can say proprioceptive loading can reduce cerebellar tremor and reaching activities. Electrotherapy techniques like cutaneous nerve stimulation, sensory stimulation below threshold can inhibit tremor without fatigue and discomfort to the patient. Active assisted cycling can decrease the tremor and bradykinesia. There are some neuropsychological techniques like voluntary suppression. So resting tremor can be suppressed by an act of will and conscious control. General relaxation technique can improve the resting and postural tremor and short-term reduction in rigidity. Meditation-based exercise program can improve motor and non-motor symptoms and improve the quality of life in patients with Parkinson's disease. Relaxation guided imagery technique also can suppress the tremor, and a systematic relaxation training can reduce stress induced by motor symptoms in Parkinson's patients. At muscular level, neuromuscular therapy can improve motor and selected non-motor symptoms also in Parkinson's patients. Whole body vibration can improve tremor and rigidity, and tremor suppressing orthosis also play a key role in tremor reduction. Weight holdings has no effect on tremors. It's proved in a study conducted by Rubia. In conclusion, the results of this review suggests the various physiotherapy techniques were useful in suppressing tremor in patients with Parkinson's disease. It can improve functional independence with decreasing tremor, improving balance, etc. All of these have a positive role on participation and quality of life. Evidence shows positive changes, but no negative effects by various physiotherapy techniques. It must become an integrated part of rehabilitation program of persons with Parkinson's disease. Various neuropsychological techniques like relaxation, meditation, massage, etc. were proved its effect in controlling tremor. The specific protocol or duration of therapy sessions are inconclusive, and the limitations are, however, the persistency of outcomes in long term is not clear in any studies. We can suggest further implications like persistency of positive changes in long-term follow-up, valid protocol and type of training can be demonstrated, and strong methodological studies with enough number of sample size can be useful for evidence-based practice in tremors in Parkinson's patients. Here, there are our references.
Thank you, Nagarjuna sir. Now I invite Dr. Manoj sir to ask questions.
Dr. Nagarjun.
Good afternoon, sir.
Good afternoon. Good afternoon. You did a systematic review.
Actually, it is a review study, sir. Actually,
study.
I planned for a systematic review, but I could not critical appraise do properly. So this is a review study, sir.
Okay. Any specific reason to select this topic?
Actually, in my clinical practice, I used to see Parkinson's patients. They had tremors, and we usually working for balance, posture, gait, other abnormalities, and they are complaining about tremors. But so I tried, like I consulted my seniors, my colleagues, other staff, but everybody suggested like meditation, breathing exercises, yoga, and relaxation techniques. Those things we are suggesting, but when I try to get the evidence-based practice, nowhere I got like so few articles I got, but that is mostly psychotherapy, and they have done by psychologists. But the physiological techniques, neurophysiological techniques I got, but neurophysical and related to muscle relaxation and other effects. But in practice, when we thought about this relaxation technique, for example, jog-ups and those techniques, we used to suggest to patients, and we had seen the good results, but evidence for that I have not found. So in order to get that answer, I tried this.
Okay.
Basically, this is my first step for my PhD thesis.
Okay. That's a good thing. Just to ask you, in conclusion, you said you selected some moderate quality study. What do you mean by that moderate quality study?
So basically, like I used, I thought to do systematic review by using Pedro and other Pedro and particular scale, and but I didn't get that much time. Like with short notice, I tried. So then clinical appraisal tool, basic clinical appraisal tool only I used. So that is for is it the research methodology they have appropriate or not, and have they mentioned about sample size and protocols, whatever they have used, is it evidence based or pilot study? So those things only I used, and I graded level of evidence based on the research methodology design. That's all.
Design, okay. Because when
yes.
Okay, because you suggested something like moderate, so that is nice. When you want to do, try to use the protocol, either concert or other things, to do a systematic review. Another thing, when you said that you used even case studies and pilot studies, I don't think that will be a good idea, isn't it? For a review. For a review.
Basic review, I like full RCTs. I have got only 4 or 5. More than that, I don't. So then I stepped like few case studies, and then I included case studies and reports and pilot studies.
Yeah, that is actually when you look at the evidence triangle, the case studies and the pilots are in the lowermost evidence.
Yes, level 3 and level 4.
So if you have some evidence based on that, you cannot really give credit to it, because when you're trying to do a review, you should be either the topmost should be an
RCTs. Level 1, level 2, meta-analysis, systematic reviews, RCTs only.
So that
in first stage, I filtered for systematic reviews and meta-analysis and RCTs, and only 2 systematic reviews I got. No meta-analysis I have done, and 4 RCTs I got. So then I included for my like understanding basically.
What I would do if I had that is a better point for you to suggest that less study is being done in that area, isn't it? So that itself is a selling point for you when you have less studies in that area, so you want to do research in that area.
So more scope.
Yes, so that is the only thing. The outcome, so what was the conclusion? That physiotherapy plays a role in maintaining the tremor.
Few techniques were there. Few used superficial electrical stimulation. Few used meditation, yoga therapy. And, but there where sample size is very not enough, I feel. And long-term studies, they have done like mostly 10 weeks or 12 weeks maximum.
Okay. So in that again, when you talk on tremor, again there are 2 types, different types, isn't it? You have something at resting and something as intentional and all that. So you should have, if you would have highlighted more on what type of tremor reduced and all that.
Resting tremor I concentrated, sir, but they in studies now they have mixed resting tremors and essential tremors. Most of the studies they have mixed it.
Okay.
Specifically, resting tremor, only 1 or 2 researchers have done. So most of the articles they have mixed resting tremor, essential tremor, and few they mixed with postural tremor.
Okay. Okay. Okay then. Okay then. Thank you.
Thank you very much.
Okay, thank you, Dr. Manoj sir and Dr. Nagarjuna sir.
Thank you.
Next, we move on to other candidates. Dr. U. Nambiraja from Wales Institute of Technology and Advanced Sciences from Chennai.
Good evening, one and all. My topic is effects of inspiratory muscle training in chronic bronchitis. My name is Nambiraja. I'm a research scholar in Wales Institute, Chennai. Introduction to the topic. Chronic bronchitis can cause systemic alteration such as systemic inflammation, skeletal muscle dysfunction, peripheral muscle weakness, Inspiratory and expiratory muscle weakness caused by changes in the composition of the muscle fibers and muscular atrophy. Respiratory muscle training is a part of the rehabilitation for chronic bronchitis subjects, as it promotes benefits such as improved pulmonary function and respiratory muscle strength and reduction of dyspnea, severity, improved exercise tolerance, and enhanced functionality of the quality of life. Studies that prove efficacy of inspiratory muscle training, IMT, in subjects with chronic bronchitis are well documented in literature, demonstrating that this training leads to a reduction of dyspnea and improvement in the pulmonary function, respiratory muscle strength, and functional capacity. You can see the picture of the normal bronchus and the bronchitis, how the lumen is affected. So the thickness of the wall increases and that reduces the airflow. So COPD, chronic obstructive pulmonary disease, is a chronic intensifying lung disease that affects a large number of people around the world. Patients must receive medication for the remaining of their lifespan because it is incurable. It's a crippling illness and that limits the patient's movements and turns into a social burden without high economical risk due to frequent hospitalizations. It's a background of the pathology relative contraction force here. The picture is here. So PI max, no fatigue and critical zone. There's a fatigue noted in that. Relationship between the relative contraction force of the respiratory muscles in the healthy subject and a patient with a chronic bronchitis. Objectives of the study: to determine the effect of the inspiratory muscle training on improving the quality of life and functional capacity of the patients with chronic bronchitis. To determine the effect of control group on improving the health, quality of life, and functional capacity of the primary patients with chronic bronchitis. To compare the effectiveness between the inspiratory muscle training and control group in improving the health, quality of life, and functional capacity of the patients with chronic bronchitis. Materials and methodology: study design, quasi-experimental study design, study setting, Shri Aisirvel Mission Hospital, Talambur. Duration of the study 8 weeks, 3 sessions per week for each group. Measurement tool PFT measures a long-term decline in FEV1 and to measure FEVC. The ratio between the FEV1 and FEC to be calculated to measure the pulmonary capacity of the patients, FEV1 by FEC ratio, and the 6-minute walk test, 6 MWT. The sample size 15 samples for each group. Inclusion criteria: subjects with moderate chronic bronchitis, FEV1 by FEC less than 70%. Subjects age 40 to 60 years, both male and female patients, hemodynamically stable patients. Exclusion criteria: patients with comorbid medical conditions, heart disease, ischemic heart disease, acute myocardial infarction within 3 months, cardiomyopathy, and valvular heart disease. Outcome measures: forced vital capacity and forced expiratory volume FEV1 improved greatly in both IMT and control groups. In the 6-minute walking distance, each group revealed a substantial improvement. Study procedure: for this study, 15 patients with moderate chronic bronchitis were selected for each group. 2 groups were formed as IMT and control group. They were given inspiratory muscle training and breathing retaining exercise ranging from 15 to 30%, 60% of their maximum capacity and breathing capacity. In addition to their prescribed drugs, both the groups received training and exercise for 3 days a week for 8 weeks. So flowchart of the study: inclusion criteria and exclusion criteria of the selection sample. Improving the functional capacity of the chronic bronchitis, we are dividing into 2 groups, group A and group B, and we are testing for the pre-test values and the post-test values. So pre-test values including the FEV1 by FEC ratio and the 6-minute walk test. And the intervention is for about 8 weeks inspiratory muscle training we are giving, and the other one is a control grouping. So post-test values: pulmonary function test, FEV1 by FEC ratio, and 6-minute walk test. And the follow-up and the data analysis performed, and group A and group B is compared. Results: both the genders, male and female, contribute to the patient selection for the disease severity was moderate. 2 groups of 15 chronic bronchitis with moderate severity of disease were selected for IMT and control group for a period of 8 weeks. Pre-test and post-test values are compared for both the groups. So here comes the results of the comparison for the pre-test and post-test values. FEV1 by FEC ratio of IMT group with a 0.05 p-value, so 0.627 and 0.638 respectively, and comparison with the control groups for the pre-test and post-test values, 0.622 and 631. The p-value of 0.05. So it's a graphical representation for FEV1 by FEC ratio. And this is the 6-minute walk test. Post-test values of the 6-minute walk test observed 58 and 42 for IMT group and the control groups respectively. So this is a 6-minute walk test graph representation: IMT group and the control group, inspiratory muscle training group and the control group. And here comes the discussion. In the present analysis, the patient with the inspiratory muscle weakness, PI max 60 centimeter of water, were more likely to improve inspiratory muscle strength and functional exercise performance when IMT was applied. In addition, studies including patients with a low baseline PaO2 and high baseline PaCO2 had more improvement in inspiratory muscle strength achieved by the IMT. It is believed that when the expiratory muscle effort, ratio effort of actual pressure over the maximum inspiratory pressure, PI max, exceeds a critical level, breathing is perceived as unpleasant. By improving respiratory muscle function, reducing inspiratory load, and the aim is to reduce the relative load on the muscles, Study from Journal of Applied Physiology. Conclusion: so as to achieve the improvement in pulmonary function test, respiratory muscle strength, and 6-minute walking distance, both IMT and control groups used in pulmonary rehabilitation programs for chronic bronchitis patients with mild airway blockage. The IMT group is comparatively show little increased effects than the control group in the post-test values. Selecting an IMT and control group strategy initiates a thorough understanding of both the treatments available and the individual condition and the needs of the patients being treated. References are arranged in APA order. Reference APA format. Thank you one and all for this.
Thank you, Dr. Nambiraja, sir. Now I would like to invite Dr. Manoj sir to asking the question.
Dr. Nambiraja, just what was the thing you used in the control group?
Good morning, sir. I have used the general techniques like breath holding technique and breathing retraining techniques for the control group, sir.
Okay, then the experimental group.
That one group which I tried is like only with the inspiratory muscle training, sir. The other group is for the control group.
So what did you do for inspiratory muscle training? What exercise protocol you followed?
Yes, sir. I followed the inspiratory muscle training alone with the inspiratory muscle trainer. The 3 sessions per week, sir, and it was for 8 weeks duration.
Okay. Okay. For chronic bronchitis, inspiratory muscle training is the norm which has been done, isn't it?
Yes, sir. Yes, sir.
So what is novel or what is new in your study?
I expected that inspiratory muscle training will be a new type of technique for giving functional capacity for the patients with chronic bronchitis. So that I expect from the study.
Okay, but even otherwise, what is the normal protocol you do for a chronic bronchitis patient?
Generally, we follow the diaphragmatic breathing exercises and force expiration techniques for the chronic bronchitis patients, and to removal of airway clearance techniques.
Okay. Okay.
So in that case, this will be a little better for them.
So that you thought, okay, you what were your outcome measure to assess the inspiratory muscle strength?
I selected the FE1 by FEC ratio and 6-minute walk test for the groups. Post expiratory volume in 1 second and post vital capacity, that ratio difference of the two, and the 6-minute walk test.
6-minute walk test for inspiratory muscle power.
That is for the general fitness of the patient, sir.
Yeah, that's okay. For the fitness, it is agreed. So my question was anything which is specific to the inspiratory muscle.
Yes, sir. PFT. So in that PFT, I'm selecting the FE1, FEC, and FE1 by FEC ratio.
Okay.
The 3 parameters I selected.
Okay. So you thought in that you saw, was there an improvement post test?
Yes, sir.
In which parameter there was an improvement?
I expect that FE1 by FEC ratio will be showing the little difference comparing to the control group. So the ratio difference, yeah, yes, sir.
But your results said that both were more or less the same. There's not much of a significant difference.
Much of significant difference still I have found. So only 15 patients were selected till now. So I try to expand the number of patients more than this, so that I can find much more better difference.
Okay. Okay. Fine. Did you use any weights to increase the muscle strength and other things? Any technique like that?
Till now, I have not used that technique, sir.
Okay.
So in my further studies, I shall include that also.
Fine.
Yes, sir.
Okay. So what is your this pilot study is leading to what? What is the other study? What is that you're going to do?
Yeah, I can compare with the IMT with some other training techniques to implement for the chronic bronchitis patients.
Okay. Then.
Yes, sir. Thank you, sir. Thank you.
Okay, thank you, Dr. Manoj sir and Dr. Nambiraja sir.
Thank you.
Next, I will call upon.
Sorry to interrupt. How many more candidates do we have?
Yeah, sir. 2 candidates, sir.
2. Okay.
Okay, sir. So I would like to invite Dr. Yanika Dey Yagnik Dev from Marwadi University, Gujarat.
To compare the effectiveness of inspiratory muscle training versus alternative nostril yoga breathing on blood pressure, resting heart rate, and quality of life in secondary hypertension. It is an interventional study. Many times we have found that during the consultation, we came to know the patient is also suffering from the hypertension. It may be a primary hypertension or it may be a secondary hypertension. So many times what we are doing, we are prescribing some kind of the exercise and giving some kind of the suggestions like the lifestyle modifications, and majority of the time patient are not following the instruction. So basically, let's start. What is hypertension? Hypertension, the increasing in the blood pressure, it may be systolic or systolic as well as diastolic. Then it can be termed as the hypertension. Broadly, the hypertension is classified into two: primary, or it can be also known as the essential hypertension, and the secondary hypertension. The other types are also there, like the white coated hypertension and resistance hypertension. So what is primary, or you can say the essential hypertension? Whenever without any kind of the known cause, the blood pressure is increased, then it can be termed as the primary hypertension. So in the India, 26.5% prevalence rate is there for the hypertension. So majority of the cases are suffering from the primary, or it can be known as the essential hypertension. Among of them, 5 to 7% of the cases are suffering from the secondary hypertension. So what is secondary hypertension? With the known cause, with some reason, if the blood pressure is increased, then it can be termed as the secondary hypertension. Like any hormonal disorders are there, any renal disorders are there, or any autoimmune disorders are there, then it can be termed as the secondary hypertension. So in this study, the independent variables are inspiratory muscle training and the alternative nostril yoga breathing technique included. And between the two independent variables, the comparison was shouted. The dependent variables are blood pressure, resting heart rate, and quality of life. Specifically, that is termed as the Minishal scale that included for measurement of the quality of life, which is specifically applicable for the hypertension. So what is the need of this study? As we know very well, hypertension remains most important public health challenge. And we know very well, whenever we are doing any respiratory modulation, it is also related with the cardiovascular modulation. So like we are prescribing the deep breathing exercise, slow deep breathing exercise, diaphragmatic breathing exercise, inspiratory muscle training, alternative nostril yoga breathing technique, then aerobic exercise. So in that cases, ultimately directly it is affecting or influencing on the autonomic nervous system, and ultimately it is playing a very important role for the management or for the maintenance of the blood pressure as a non-pharmacological management. Definitely along with the pharmacological management, the non-pharmacological management is also very important in the hypertensive patients. So objective of the study, to find out the effect of inspiratory muscle training on blood pressure, resting heart rate, and quality of life in patient with the secondary hypertension. To find out effect of alternative nostril yoga breathing on blood pressure, resting heart rate, and quality of life in patients with the secondary hypertension. And to compare the effect of inspiratory muscle training versus alternative nostril yoga breathing on blood pressure, resting heart rate, and quality of life in secondary hypertension. Methodology, the primarily ethical clearance was taken, and the study setting was Marwadi University Research and Rehabilitation Center in the Rajkot city. The patients were randomly divided into two groups, Group A and Group B. Equally 14 patients were divided in both the groups, and in the Group A, alternative nostril yoga breathing technique was given for 15 minutes, 5 days per week, and for the 4 weeks. In the Group B, the inspiratory muscle training was given for the 15 minutes, and 1 minute rest period was given between the two sessions, and 5 days per week. For the 4 week, the treatment was given. The inclusion criteria: secondary hypertensive patients with no change in any medications for at least 2 months proceeding for the study. Both gender, male and female, included between 35 to 65 year age, and BMI between 24.01 to 28.08 kilogram per meter square. Exclusion criteria: tobacco, smoking, alcohol consumption, athletic population, or those who are doing regular pranayama, nasal abnormality like the nasal polyps, and recent cardiovascular or pulmonary surgical events has been happened and surgery has been done, that has been included from this study. The outcome measure pre and post measurement were taken after taking the consent. Systolic, diastolic, blood pressure measured, resting heart rate, and the Gujarati version of the quality of life questionnaire included as an outcome measure. In this result, you can see in the alternative nostril yoga breathing technique as well as in the inspiratory muscle training, in the systolic, diastolic blood pressure and quality of life, as well as in the heart rate, the pre and post measurement were taken, and after application of the normality, the data is following normality. So for that, the T test has been applied, and here for the pre-post measurement comparison, the paid T test applied, and in the systolic blood pressure, heart rate and quality of life, the significant result was found in the both the group alternative nostril yoga breathing as well as in the inspiratory muscle training. Whenever we have done the between group comparison by utilization of the unpaid T test in the systolic blood pressure, diastolic blood pressure, heart rate and quality of life, so in that the significant result was founded. The between group comparison, more improvement was founded into the inspiratory muscle training group. As we know very well, the congestion and decongestion nasal cycle is normally following and normally it is present. So for example, half an hour our right nostril is active, then after that for the another half an hour our left nostril is active. So ultimately whenever we are playing with the respiratory modulation by the alternatively right as well as the left nostril, so it will ultimately balancing our sympathetic and parasympathetic tone. So ultimately it is reducing the our blood pressure. As we know, whenever we are doing the respiratory muscle training, so it is also modulating our vagal tone, so it is reducing the blood pressure. So the conclusion of the study, both the study group has significantly founded improvement in systolic blood pressure, resting heart rate and quality of life, but more improvement was founded into the inspiratory muscle training group, where there was no significant difference founded in the diastolic blood pressure in the both group. Thank you.
Thank you, Dr. Yagnik, sir. Now I invite Dr. Manoj, sir, to ask questions.
Yes, Yadnik. Different.
Very good afternoon, sir.
Very good afternoon. You wanted to do a different study. Just a few questions. What did you want to term under IMT? What do you normally do?
Inspiratory muscle training. Yes, sir. Inspiratory muscle training. One threshold loaded device is there that directly patient has to introduce inside the mouth, and they just have to take the deep breath from this particular device only. So this is termed as the inspiratory muscle trainer. This instrument is termed as the inspiratory muscle trainer. Ultimately, it is providing the some kind of the resistance during the inspiratory maneuver.
Okay, so what is the what is it to find out with this inspiratory muscle trainer? What do you find out with this? What do you find out with this inspiratory muscle trainer? Is it the muscle power, or what do you intend to find with this?
Sure. Here the intention was directly the affection on the autonomic regulations, whether the inspiratory muscle training is influencing our autonomic nervous system or not. So my prime aim was to find out the effect of inspiratory muscle training on the resting heart rate as well as on the blood pressure, sir.
Okay, I'm just asking out of curiosity. Normally, if there's any training or exercise which you do for hypertension, wouldn't it be a relaxed breathing exercise? I'm just asking.
Yes, sir. In the whenever we are influencing on the our diaphragm muscles, whenever we are strengthen our diaphragm muscles, so ultimately it is also affecting the metaboflex. So the SpO2 level, which will be ultimately increase inside our body, and ultimately it is affecting our central chemoreceptor as well as the baroreceptor. So ultimately it is maintaining our blood pressure as well as the resting heart rate, sir.
Okay. Another thing, in the inclusion criteria, you have taken patients with the secondary hypertension.
Yes, sir.
Is it correct, or you want to add on something? Is it only secondary hypertension or primary hypertension?
Yes, sir. No, this is the secondary hypertension. In that, the most commonly those who are having the three kind of the disorders. First one, that is the renal disorders, then the thyroid dysfunction, and those who are having the adrenal dysfunction. This kind of the patients were included in this study, sir.
Okay. Any specific reason you wanted to take secondary hypertension?
Sir, many times we are just focusing on the essential hypertension because of the larger population or larger prevalence rate is there. So higher prevalence rate is there. So we are not more focusing on the secondary hypertension. That's why I have done this study on the secondary hypertension.
Okay, if you are doing on secondary hypertension, as the name denotes, it has to do with some renal problem. So you think your breathing exercise is going to regulate the renal problem to reduce the hypertension? Hello?
Yes, sir.
You can
No, sir. Directly, it is not affected whenever we are influencing on our autonomic.
Yeah, I would agree if it is essential hypertension you are doing in this inspiratory muscle training to reduce the hypertension. Yeah, audible. Yeah. I would agree if it is inspiratory muscle training is done for essential hypertension, where based on the system, like your parasympathetic nervous system, it can alter. But I don't know how much. I don't know how much it is going to be effective on a secondary hypertension.
Yes, sir. Secondary hypertension, in that also the indirectly the influence is there by the influencing on the autonomic nervous system, sir.
Okay. Okay. Fine. Okay then. Thank you.
Sir. Thank you, sir.
Thank you, Dr. Manoj sir and Dr. Yagni sir. Thank you. So our last contestant, Dr. C.K. Muralidharan from Nanda College of Physiotherapy.
Morning. My topic is comparison of modified razor curl and Nordic hamstring curl exercise in improving the hamstring muscle performance among male volleyball players. Actually, volleyball players involves the movement requiring different muscle strength at fast and slow tempos. The performance of the volleyball player is directly affected by its power production capacity. In addition to the muscle strength and power is an indivisible part of the sportive performance. The muscle strength and power is an important component in sports in terms of exhibiting high performance and preventing injury. Improving the muscle strength and the power is mostly important for players for improving the functional agility, speed, performance, etc. In this manner, there are several types of training person. For example, isometrics, isotonics, and concentric and or eccentric. Currently, the study shows that eccentric training is more advantage than concentric training, such as improving the power, strength, cardiovascular fitness, adaptations, and conditioning. Razor curl. It's an useful exercise method, an alternative way to deal with train hamstring muscles in more practical positions. The razor curl is an exercise technique adapted from the razor curl exercise, and this modification was clinically proven to have appropriate level of effectiveness. Due to the lack of equipment in the gym floor, modified razor curl seems to be best alternative method to train the hamstring muscle groups, since there is no specific equipment is needed. The Nordic curl exercise was, on the other hand, it has been presented as an exercise of alternative method to train the hamstrings with better eccentric and concentric contractions approached without depending on gym equipments, more precisely as weight training. As reported in the study, the functional training approach such as Nordic curl exercise often used in the rehab sessions among the injured athletes as the tool of injury and prevention, especially for biceps and semitendinosis. The objective of the study is to have a depth knowledge in strength and power of the various muscles contractions, to have a depth knowledge in modified razor and Nordic hamstring curl, to have a depth knowledge in daily adjustable progressive resisted exercises, and to follow the regular protocol. It has been the adjustive protocol to improve the muscle strength and power of the hamstring muscles among the male volleyball players. The study design, it is a quasi-experimental study design. Study setting, it is an outpatient department in Nanda College of Physiotherapy, Erode, and Nanda College of Arts and Science students, and men's volleyball players. Sampling method, it is a convenient sampling method. The study population, the players with the age group of 18 to 25 years of male, and they should not have any recent injury, specifically knee and ankle. And the sample size is 40, and it is divided into two groups. Group A in 20 players who are trained by modified razor curl exercises, and Group B players which are trained by Nordic hamstring curl. Study duration. The duration is conducted for the period of 10 months. Criteria for selection. Inclusion criteria. Male volleyball players with normal health conditions. Age group between 18 to 25 years. Players have a routine regular strengthening program, and they should have a minimum of 15 kg of one repetition maximum, and they should be free from hamstring injuries at least 6 months before. Then recreational athletes will be preferred. The exclusion criteria: players with a history of any lower limb fractures, players with a history of drug allergies, uncooperative players, then players with any ulcerations in the lower limb or any disorders in the knee, players with recent hamstring injuries, players with any vertebral, core or gluteal injuries. The outcome measure, it is an one repetition maximum. It is defined as the greatest amount of the weight a muscle can move through the available range of motion, specific number of items. Then the next outcome measure is a 40-yard dash test. Next outcome measure, it is a Superman exercise test. Then the training protocol: modified razor curl, kneel in starting position, both knees flexed, around 110 degrees, hips extended, both knees were supported, and reduce the friction of the knee surfaces. Ensure that the player's feet were in contact with the ground or couch throughout the exercises. Subjects are requested to move his upper body to lean forward into 90 degrees position. They were asked to try to maintain 4 seconds and return back to the normal position. Usually the frequency of exercise is 3 sessions per week, 30 minutes with warm-up of 20 minutes and cool-down of 10 minutes. Actually, Nordic hamstring curl exercise: kneel in starting position with torso from the knee held upwards, rigid straight. Ensure that players' feet were in the contact with the ground throughout the exercise by sitting in both knees and applying pressure over the player's heel and lower legs. Instructions were given to the players to lower his upper body to the ground slowly as possible to maximum loading exercise in the eccentric phase. Hands and arms were used to break his forward fall, to push him back after his chest had touched the ground, and to minimize the loading in the concentric phase. The frequency of exercise is 3 sessions per week, 30 minutes with warm-up 20 minutes and cool-down of 10 minutes. This is the pictures demonstrating the modified razor curl and Nordic hamstring curl exercises. This is my data presentation for the 3 outcome measures. The results of the one-arm test 40-yard dash, which shows that Nordic hamstring curl was more effective than modified razor curl for players with weak hamstrings. But the pad test p-value of Superman exercise shows that modified razor was effective than Nordic hamstring curl in the activation of the core muscles like longissimus and iliocostalis.
Okay, thank you, Dr. Muridharan sir. Yeah, Dr. Manoj sir. I think Dr. Muridharan sir is not available because of poor connectivity, I think so.
Yeah, it's okay. It's okay then.
Yeah, sir. Okay. Sir, our principal sir wants to convey some message with you.
Okay.
Shall I hand over? Okay, sir.
Thank you, Manoj sir, being with us.
Thank you, Sir, I'm not able to hear you, sir.
Dr. Manoj, sir.
Yes, sir. Yes, sir.
Good afternoon, sir. Thank you for being with us, sir.
Thank you. Thank you for the opportunity. First and foremost, I would like to congratulate Dr. Shivakumar, Dr. Pradeepa and his team for organizing such a wonderful event at this time of pandemic to have this international virtual conference where many have come and present. So congratulations and keep up the good work. Hope you do more, sir.
Thank you, sir.
And thank you for the opportunity where I could be part of this. Thank you very much, sir.
Thank you, sir.
Thank you, sir. We are very thankful to Dr. Manoj Abraham, sir, to be with the part of this session. And we are very grateful, sir, for your valuable time and which you have shared with us. Thank you so much, sir.
Thank you, ma'am.
Thank you, sir. So now it's time to end our paper presentation. I also extend my thanks to all the delegates for this enthusiastic participation. So by this, we have come to end of our first session of PhD faculty, scholars and faculty paper presentation. After a lunch break, we will be having a second session of paper presentation by 2 p.m. We are looking forward of your valuable feedback. Feedback will be uploaded in www.physiocon.com website under the virtual auditorium page at the time of 3 p.m. After the submission of feedback only, you will be receiving the e-certificate of participation. You will receive the participation certificate of paper and poster presentation by 13th of September 2021. The winner of quiz competition, poster and paper presentation will be announced in the validation function, which is scheduled at 4:30 p.m. today, and the link will be shared in the WhatsApp group by 4 p.m. I kindly request you all delegates to join the validation function. Thank you. Have a nice day.